Yeah, we are live now. So, good morning, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar. So, today we are on the virtual learning series on preeclampsia, organized by the Society of Maternal Fetal Medicine, Series 2, Episode 3. So, it's my privilege to introduce the moderator of this webinar, Dr. Akshita Seth ma'am. Ma'am has done MBBS, DNB, and in OBG. Ma'am is consultant at Manipal Hospitals, Malleshwaram, Bengaluru, visiting consultant at Manipal Hospitals, Yeshwanthpur, Bengaluru. Ma'am has areas of interest in screening and prevention in high risk pregnancy, well woman care, and family planning services. I welcome you, ma'am, and I hand over the session to you.
Thank you, Saiti, for the wonderful introduction. Namaste, everyone. I'm Dr. Akshita here. I welcome you all to the Virtual Learning Series 2, Episode 3 on preeclampsia. Today, we will be learning about renal disorders and preeclampsia. We will first have our welcome address by our president, followed by 2 capsule lectures by specialists, and then the panel discussions. Also, today we have a special launch for the PenI, so stay tuned for a good learning experience. I now welcome our President of Society of Maternal Fetal Medicine India and Chairperson for today's session, Dr. Prakash Mehta, sir, to deliver the introductory address. Over to you, sir.
Good morning, everyone, and thank you for joining on this Sunday morning. Let me first introduce the SMFMI to those who are still uninitiated. This is a consortium of like-minded obstetricians and gynecologists along with other multidisciplinary specialties. And we have taken preeclampsia as one of our main topics because we all know that once upon a time it was postpartum hemorrhage that was the commonest cause for death in maternal death in India. Now, preeclampsia has overtaken the postpartum hemorrhage, and it is possibly the commonest cause for death in preeclampsia. So if we control preeclampsia, probably we'll be able to save many more women. And that is why the society has taken up this particular topic with great interest. We all know that we have the Preeclampsia Education Nation of India program, where all the basics of preeclampsia are considered. And as a continuation and as a further upskilling of the health workers, we have this kind of a program where we go into deep details about one particular topic of preeclampsia. So today I'm happy to say that we have the topic on preeclampsia and kidney, how the kidney is affected in preeclampsia, how the kidney afflictions affect preeclampsia, and so on. And I'm very happy to say that we have faculty, all experts from all over India and across the globe. We have Dr. Renumaka Shanmunglingam already joining us, and she'll be speaking on the prenatal care for these women. And then, of course, we'll have Dr. Arun, who is a nephrologist from my own hospital, will be joining. Dr. Malini is from Hyderabad. Dr. Bharti Sharma is from Chandigarh. Dr. Sushma Madhuprakash is our very own from Bangalore. She is one of our core members. Okay, and we have in SMFMI, we have always made it an endeavor to ensure that the youngsters get their due. Okay, experience counts, fine, but at the same time, a younger blood adds on to more dynamism to the society, and that is why we have always made it a rule that yes, we have a right mixture of the seniors and juniors, so that the whole program, is full of dynamism. And so this will be our third program in this VLS PE Series 2. Our next program is going to be on hepatic disorders and preeclampsia. So please be ready for that. The date will be announced very shortly along with the faculty. And I would expect that all of you would also join us for that. Apart from that, we have a very important program today. We held the ISSHP 2023 last year in Bangalore, and the recording of that program, mind you, the who's who in the world of preeclampsia were there in that conference, and all the recordings we have made, and we are going to have a launch of those recording program today. And this program is being offered free, absolutely without any cost to all those who are part of the Penai program. Okay. And also we are developing the Penai program in a much better way now. We are going to have 4 zonal conferences, and we are hoping to train at least 800 obstetricians across India, 200 at a time in each zone, so that these people would also be able to take benefit of this iShip World Congress recording. And we are also, of course, Dr. Revati will be telling to us in detail little later, but we are also going international with Penai. We are going to call it just Pen, because Penai is preeclampsia education of nation India. So now we have changed it into Pen so that we go across the world. And although we have already had members from UK, Afghanistan, Pakistan, and so on, we would definitely want it to spread in a much bigger way. And Roche, who is one of our knowledge partners for preeclampsia education, will be partnering with us for this program also. So welcome all. And with this, I hand over back to Dr. Akshita to continue with the program.
Thank you very much, sir. I'd now like to welcome Dr. Renuka Shanmulingam, Madam, to talk to us about preconception evaluation of a patient with renal disease. Madam has made remarkable contributions to the field of renal obstetrics. She is a nephrologist and obstetric medicine physician at Liverpool Hospital, Sydney, Australia. She's an executive council member of the Society of Obstetric Medicine Australia and New Zealand, that is SOMANS, head of the SOMANS Education Committee, and lead of SOMANS's Hypertension and Pregnancy Guideline 2023. Her areas of interest include hypertensive disorders of pregnancy, aspirin, post-preeclampsia care. Over to you, Madam.
Thank you very much, Dr. Akshita, and also Dr. Prakash. I will try and share my screen, but it just says that I can't share just as yet. Let me just try that again. All right, excellent. Can you see my screen there?
Yes, it's well seen. Only you need to make it full screen.
Perfect. Thank you. Thank you for your patience with that. So I'd like to begin by really thanking the organizing committee for giving me this privilege of presenting at your wonderful Penai webinar. It's an absolute privilege. So my presentation today really is on the preconception care of women with chronic kidney disease. Well, while the focus is definitely to try and minimize the risk of preeclampsia in these women, the scope is a little bit broad, and I would be covering on that with a specific focus on lupus nephritis. So why is preconception care actually important? So it's really interesting that the first article that described pregnancy in women with renal disease was published in 1975. And the author of the paper actually stated that children of women with renal disease are either born dangerously or not at all. And not at all if their doctors had their way. And that was essentially true for a very long time, where pregnancy in women with renal disease was somewhat contraindicated due to the complications that can arise. And whilst it is becoming a bit more of a norm now, thanks to the improvement in treatment and also IVF technology, it is still not one that comes without its risk. We know that women with renal disease who fall pregnant have a 20 to 50% risk of preeclampsia and also the associated preterm birth. They have about 70 to 20% risk of increase in the risk of worsening renal impairment, and also have a substantial risk of miscarriage or the FDRU. However, this does not always need to be the case. These statistics can look a little bit better, particularly if women have good preconception care. And this is because we know that when women have preconception care, we improve engagement between the patients and their clinicians. We prevent unplanned pregnancies, and we reduce birth defects that are often associated with the medications that we use in managing these women. And so this is where preconception care is key, because it provides us with that wonderful opportunity to reduce the risk of maternal and reduce the rate of adverse maternal and obstetric outcomes. So before I go further into the presentation, I just want to take a few seconds to clarify the key definitions that I'll be making reference to here. So conventionally, chronic kidney disease is often identified or recognized when there's an impairment in the glomerular filtration rate, which is also better known as eGFR. But technically, if a patient has a normal GFR but has persistent proteinuria or microalbuminuria, that in itself it constitutes chronic kidney disease, but that is the very early stages of chronic kidney disease, like stage 1 and stage 2. And as a renal physician, those are the patients who I really want to see, because those are the patients in which we have an opportunity to make a difference to prevent progression on with time. However, when the patient does have established abnormal GFR, the patient can then fit into a spectrum or classification of CKD. So this is basically from stage 1 to stage 5. And stage 5 essentially refers to someone with an eGFR of less than 15. And this is essentially someone who requires dialysis or requires transplant. So now that we've got that in context, I just want to elaborate a little bit on what CKD and pregnancy actually means when they are put together. When we talk about chronic kidney disease and pregnancy, women and their clinicians quite often have two common questions. Their consideration essentially are, what would be the effect of their known chronic kidney disease on the outcome of their pregnancy? And also, what would the impact of the pregnancy be on the progression of their chronic kidney disease? So the data tells us that the risk of progression of chronic kidney disease with pregnancy really comes down to where she begins with the status of a renal impairment at the time of conception. So if you have a patient with stage 1 or stage 2 chronic kidney disease, so this is essentially a lady with an eGFR of more than 90 or more than 60, or even a normal eGFR of more than 90, but with the presence of hematoproteinuria. So her risk of progression of renal disease is about 7.6 to 12.5% within 5 years of delivery. Now, if she has stage 3 or stage 4 CKD, as you can see, the risk here progresses on. This is not really applicable to a patient with stage 5 kidney disease, as she already would often be established on dialysis or is close to requiring dialysis. But how do we translate this information to our patient? Because this might not mean much to them. So what the data essentially tells us is that for women with stage 3 chronic kidney disease, when they undergo an uncomplicated pregnancy, they lose about 1 to 2 years of their kidney lifespan. This value is doubled if she does develop preeclampsia, particularly early onset preeclampsia, as the physiological changes that occurs with early onset preeclampsia can accelerate the progression of a chronic kidney disease, irrespective of the etiology of a chronic kidney disease. Now, if you have a lady with stage 4 or near stage 5 chronic kidney disease, she loses about 3 to 5 years of their kidney lifespan. And again, this is close to double in women who develop early onset preeclampsia. So not entirely negligible. Another important discussion in the preconception period for women with stage 3 to stage 4 CKD is the risk of initiating dialysis in pregnancy. Now, I won't go too much into this, as I know the next speaker will provide a fantastic talk on dialysis in pregnancy. But just suffice to say that when we counsel women with stage 3 and stage 4 chronic kidney disease, once again, irrespective of the cause of underlying renal disease, it's important for her to understand the risk of initiating dialysis in pregnancy. And this is pretty substantial, as you can see from the values here. An important point to note, and again, without going too much into the next presentation, is to note that the indication to initiate dialysis in pregnancy is very different from the conventional indications to start dialysis in a non-pregnant patient. Here, we are essentially starting dialysis to keep the maternal serum urea to less than 15, really for fetal protection to ensure fetal well-being. So it's not really similar to how we would initiate dialysis in the normal circumstances. Also important to understand that the prescription of dialysis will differ, because some of these women may require dialysis of 6 days, 6 hours a session, which is about 36 hours a week, just to get her to that serum urea of that value. So I, again, won't go too much into it, but just suffice to say that this makes up a very important discussion as part of a preconception care. just so she's prepared and aware of what's ahead in her pregnancy. Now, the effect of chronic kidney disease on her pregnancy. I'm sure it'll come as no surprise to you that all these women have a substantial risk of superimposed preeclampsia and its associated risks of preterm delivery and IUGR. And this risk continues to progress on or increases accumulatively based on the extent of her renal impairment at the beginning of her pregnancy. So with all of that overview in mind, I want to just focus in a little bit more on lupus nephritis, because this certainly seems like a topic of interest, and I think it's important we discuss the additional consideration in lupus nephritis. But before I do that, very briefly, what is lupus nephritis? Just a very brief overview for my non-renal colleagues. When we talk about categorization of lupus nephritis, that is really based on a renal histopathology. And that is important because the management of patients with lupus nephritis differs significantly based on the renal histopathology. Now, there are 6 different classifications based on the histopathology involvement, but the two that quite often causes most of us renal physicians to sweat and gray is essentially class 3 and class 4 lupus nephritis, particularly when there are proliferative or crescentic changes, because this indicates very active damage to the glomerular filtering unit that does increase the risk of progression to end-stage renal failure quite rapidly. And as you can see, these patients have a risk of developing end-stage renal disease, meaning dialysis-dependent renal disease, within 5 years of diagnosis, and that risk can be as high as 65% if it is not treated. So these are really the patients who we don't want to miss. When we talk about lupus nephritis and pregnancy, again, many years ago, there are really 2 terminologies that didn't quite go together in a sentence. But then now we have changes in therapy, and again, with advancement in IVF, these women stand a chance. But it is important we identify what the associated risks are and manage them appropriately in helping them have a good transition through their journey into motherhood. So what are the few additional factors that we need to look at for women with lupus nephritis? We know that they have a substantial risk of early fetal loss and superimposed preeclampsia. We know that. We know they have a risk of flare of lupus nephritis during their pregnancy, and this risk does differ based on the status of their disease activity at the time of conception. If you have a woman who has got really quiet, well-controlled lupus nephritis for about 6 months prior to conception, her risk of flare is relatively low. It's on the lower end of the spectrum at about 10%. However, if you have a woman who falls pregnant at the time of active lupus activity, her risk of flare can be as high as 54%. Now, we also know that up to about 40% of patients with lupus nephritis can have the presence of anti-Ro and anti-La antibodies. And as I'm sure you can appreciate, the presence of anti-Ro and anti-La antibodies is particularly relevant in the context of pregnancy, as this is associated with the risk of congenital heart block and also neonatal lupus, which is why we use Plaquenil in these women, hydroxychloroquine, in minimizing the risk of transmission and minimizing the risk of congenital heart block, which has been shown to be as effective as about 55 to 60%. Another important factor to remember is that in women with lupus nephritis, or at least 40% of women with lupus nephritis, can have at least one of the 3 antiphospholipid antibodies. And again, under normal circumstances, it may not be relevant, but in the context of pregnancy, the presence of antiphospholipid antibodies can be associated with early fetal loss, placental dysfunction, hence the risk of preeclampsia and also IUGR. But more importantly, women with triple positive antibodies run the risk of catastrophic APLS, which I'm sure, as you can appreciate, is associated with a relatively high risk of maternal mortality. And so therefore, when you see women with lupus nephritis, it is important to include these considerations into their preconception care, screening, and counseling. So what should preconception care really look like for these women? I would like to start off with fertility. Now, we know that women with lupus nephritis can have impaired fertility due to irregular menstrual cycle or history of cyclophosphamide use, antiphospholipid syndrome, or in the context of presence of the chronic kidney disease. And again, it depends on the extent of the chronic kidney disease. But again, with improved treatment and use of IVF, these issues with fertility can be overcome. I do want to, however, spend a bit of time discussing the medications that these women often would use and the preparation that is required in preparation for conception. Now, in discussing this, I've just summarized this into a few key agents that we often use. Most patients with lupus nephritis are often either on an ACE inhibitor or ARB. So this is angiotensin receptor blockades or ACE inhibitors. Now, these are quite often used in patients for hypertension, but in patients with lupus nephritis, we may use them for the anti-proteinuric effect, even in the absence of hypertension. And we know for a matter of fact that it's used in the second and the third trimester as an absolute contraindication. But the question I quite often get asked is, when should we stop these ACE inhibitors and ARBs in preparation for conception? The answer is unfortunately not all that straightforward. The largest study that's published in the literature at the moment, as I'm sure you know, is a large retrospective registry-based study that wasn't all that strong in its conclusion given the significant biasness in that study. But what we generally recommend is that if ACE inhibitors or ARBs are used specifically for the purpose of hypertension, we would recommend that they are ceased and replaced with an agent that is commonly used in pregnancy, like methyldopa, labetalol, and nifedipine at the preconception period. But this is if it's used purely for hypertension. If a patient requires ACE or ARB for its anti-proteinuric effect, so this is lupus nephritis, but also relevant to patients like with minimal change disease or membranous nephropathy or FSGS who all require the anti-proteinuric effect, we generally tend to use them up until the point of confirmed conception. But this again should be done with very strong counseling and an understanding and agreement that your patient will be able to follow through with these instructions. So this really involves a lot of vigilance on the patient's side to be able to be mindful of their period cycles and to be able to test for pregnancy tests as soon as they miss their period cycle and stop as soon as the pregnancy test is positive. Again, I would not do this for all patients. I would only do this for patients who I believe can have that relationship and trust with me in following through those instructions. Now, in terms of immunosuppressions, we do use quite a number of immunosuppressions for induction therapy in lupus nephritis. Now, some of these agents that I mentioned would also be applicable to certain conditions like minimal change disease, membranous nephropathy, and even for the renal transplant patients for that matter. So the knowledge that I'm sharing here in terms of the use of immunosuppressions can be applied broadly to all renal disease that requires immunosuppressions. So the ones I really want to focus on here are three commonly used ones. Mycophenolate. We know that the use of mycophenolate in pregnancy is absolutely contraindicated, and this is because its use is associated with the increased risk of miscarriage and also craniofacial malformation. And so therefore it is recommended that mycophenolate is stopped at least 3 to 6 months prior to planned conception. Most of these patients will require an antimetabolite replacement therapy, and in those instances, we tend to use azathioprine as a replacement for mycophenolate. It is, however, important to note that prior to initiating azathioprine, it is necessary to check for TPMT activity level. TPMT is essentially an enzyme that metabolizes azathioprine. 5 to 10% of the population can have a deficiency in TPMT activity. So TPMT deficiency is most commonly present in the Southeast Asian population. And so therefore, in Australia, where we have a very multicultural community, we do quite a bit of TPMT screening before initiating azathioprine. Now, if the TPMT level is adequate, then the patient can get initiated on azathioprine. In the absence of adequate TPMT activity, the patient runs the risk of azathioprine toxicity that can result in significant bone marrow suppression. Similar restrictions or similar caution will be applied for patients who use azathioprine and allopurinol together, where you can have bone marrow suppression, but that may not be relevant to your pregnant patient. Now, again, mycophenolate is not used in lactating women. Cyclophosphamide. Now, cyclophosphamide is an agent that when renal physicians or immunologists treat lupus nephritis in patients of childbearing age, the decision to use cyclophosphamide is not one that is taken lightly. We try and avoid cyclophosphamide use unless it is absolutely indicated. If we are discussing the use of cyclophosphamide, it is often quite often due to a significant need and desperation. And this is particularly the case for patients with significant crescent red features in their renal biopsy. Now, we do not use cyclophosphamide in pregnancy under most circumstances, particularly in the first trimester, as it is associated with significant risk of miscarriage and craniofacial anomalies. It should be withdrawn 3 to 6 months prior to conception, and it should not be used in lactating women. Now, again, just on the note of cyclophosphamide, we do know that it can affect fertility. And as I mentioned before, using this in patients of childbearing age is not a decision we take lightly. However, not infrequently, we do find ourselves in instances of requiring cyclophosphamide in these patients, particularly young women. Whilst they may not be pregnant, in the early stages, say in their 16s, 17s, or in their early 20s, if they do require cyclophosphamide, the recommendation is that we either go for cryopreservation prior to the use of cyclophosphamide or the use of GnRH agonists to induce temporary ovarian suppression. However, I must say, if we're using cyclophosphamide in this patient, we often do not have the benefit of time. And so therefore, option 1, which is cryopreservation, quite often is not all that feasible. And so therefore, we would refer to option 2, which is the use of GnRH agonists to try and preserve their fertility during the time of cyclophosphamide exposure. Now, rituximab. Rituximab is another agent that we quite commonly use. Certainly in patients, I have used quite a bit of rituximab, actually, particularly in women of childbearing age, to try and minimize the use of cyclophosphamide. Whilst it is not teratogenic, it is associated with neonatal B-cell depletion, particularly when used in the 2nd and 3rd trimester. And whilst it is not generally recommended, in very dire instances when we have significant active lupus in pregnancy, we have had instances where we have required the use of rituximab in pregnancy. But in the preconception phase, where possible, it is important that it is avoided for at least 6 months prior to conception, again, given the risk of B-cell depletion, particularly with 1st trimester exposure. Now, with the medications on board, we now need to talk about the timing of conception. When would these women actually be able to fall pregnant, given that we've spoken a lot about what needs to be done before they fall pregnant? When patients have active disease, and this is indicated by low complement levels, a significant elevated protein or renal impairment from active disease, or very active double-stranded DNA markers, these are all indications of remarkably active disease, in which case pregnancy should be absolutely contraindicated. The recommendation is that they have absolutely quite stable disease for 6 months. And even so, that 6 months, they should be stable on agents that are appropriate for conception, which means it should have been at least 6 months since their last dose of cyclophosphamide or rituximab or exposure to mycophenolate, and they should be really in stable disease state with the use of medications like azathioprine. So if she develops a flare while she's on azathioprine, her clock essentially resets, and she needs to wait for 6 months of stable activity before she falls pregnant. Now, in that time when she should not fall pregnant, another important discussion is contraception. Now, this loop really should be covered by contraception to avoid the risk of accidental pregnancy. Use of contraception for women with lupus nephritis can be a little bit tricky because, as you know, there are many reasons for them to actually form clots, and their risk of VTE can be high. And so for the recommendation is really to use a progesterone-based contraception and avoid the use of an estrogen-based contraception. In patients who are remarkably high risk, such as those who are on mycophenolate, I quite often use or recommend the use of a progesterone-based contraception in addition to a barrier contraception. Barrier contraception by itself quite often has a very high failure rate, and so therefore I tend to have these conversations with my patients and their partner present. Now, two additional considerations, as I mentioned before, is screening for antiphospholipid antibodies, and importantly, to also screen for the presence of pulmonary hypertension, secondary pulmonary hypertension, as about 0.5 to 22% of these women can have asymptomatic pulmonary hypertension, which will only manifest itself in pregnancy. And this is because the significant physiological changes that happens in pregnancy can increase the risk of peripartum mortality significantly, between 30 to 55%. And so therefore, optimization of pulmonary arterial pressures prior to conception is remarkably important. And this really should involve a significant MDT team of intensivists, obstetric anesthetists, cardiologists, respiratory physician, obstetric physicians. I'm not saying that, falling pregnant with pulmonary hypertension is a walk in the park. That is a completely different conversation and discussion on its own. But what we don't want is to have women with lupus or SLE in general and hidden pulmonary hypertension that is only identified in the pregnancy. So screening for it beforehand is certainly something that is preferred. In the interest of time, I'm going to get through this very quickly, but I want to have a very, very brief discussion on the antenatal care, particularly in the early phase, because we've discussed all their risks. But what's important is how do we minimize their risk? So preeclampsia prophylaxis, as I mentioned, these women are all at a substantial risk of preeclampsia. And so therefore, it's important that we initiate them on aspirin. The recommended dose at present is 150 milligrams a day. And as I'm sure you would know, they should be initiated before 16 weeks of gestation. And women with low dietary calcium intake, there's enough evidence to suggest that they would benefit from supplemental calcium to further minimize their risk of preeclampsia. And the other question I often get asked is, should we use Clexane in these women? Should we use low molecular weight heparin in these women? And the answer to that question really comes down to the indication for it and also the presence of APLS. So very, very briefly, if the woman, let's forget APLS for a minute. If you have a lady who has got significant nephrotic syndrome and has a serum albumin of less than 20, when you have significant nephrotic syndrome, these patients also lose a lot of protein C and protein S, which are naturally protective proteins against VTE. Now, the significant nephrotic syndrome coupled with pregnancy increases the risk of VTE substantially. So women with significant nephrotic syndrome, irrespective of the APLS antibody status, should be initiated of Clexane at 40 milligrams daily in addition to their aspirin. But it's also important to remember that these women should have their Clexane continued for 6 weeks postpartum because the risk of VTE remains persistent in the postpartum period. Obviously, the aspirin does not continue in the postpartum period. Now, for patients with asymptomatic APLS, so if you go and vigilantly screen for their antibodies and their antibodies are present, but they've never had a miscarriage or they've never had any evidence of VTE, so completely asymptomatic antibodies, the current guidelines in EULA suggest that you only require aspirin and you do not require Clexane. Having said that, the risk for ongoing VTE risk needs to be continuous. So if she does develop any other risk for VTE, such as nephrotic syndrome or preeclampsia, or if she's obese or if any other risk factors that she does develop, she will require Clexane in addition to aspirin. Now, if she does have a history of symptomatic APLS, so this is either through miscarriages, she will require the combination of aspirin and Clexane. So again, this is prophylactic Clexane, which is just at 40 milligrams a day. However, if she has got a history of a vascular event, so such as a PE or a DVT with the presence of the antibodies, she will require therapeutic Clexane, and it should be on a BD dosing of 1 milligram per kilogram in addition to her aspirin. I want to strongly emphasize that it really should be a BD dosing only because, as you know, there is an increase in the glomerular filtration rate in pregnancy, and therefore there's an increased clearance of Clexane in pregnancy. So if you were to go to a daily dose, inevitably you will end up underdosing your patients. So therefore, these patients do require a BD dosing and also a calculation or monitoring of their trough anti-10A levels. Very quickly again, sorry, I do apologize if I'm going over time, but these women are also at risk of gestational diabetes, because quite often they do require the use of prednisone as part of their suppression therapy. And as you know, long-term use of prednisone is associated with the risk of gestational diabetes. And so all these women should have a first trimester early OGTT. Diagnosis of superimposed preeclampsia can be quite difficult, but this is where we do use the angiogenic biomarkers where available, such as the PLGF and soluble FLT1 PLGF ratio, to be able to help us differentiate between placenta-mediated dysfunction, also physiologically mediated dysfunction, or a flare of lupus nephritis in pregnancy. And finally, as I mentioned before, you can have an acute flare of lupus in pregnancy. So not all rise in protein in these women is just preeclampsia. It sometimes can be lupus nephritis, but it's hard to differentiate that. And this is where the biomarkers and clinical indicators may be quite beneficial. Now, in the interest of time, I'm going to stop there, but I do apologize for having rushed through the last few slides, but I'm most certainly happy to take any questions that you might have. Thank you again.
Thank you very much, Dr. Renuka, for sharing your expertise here today. Yes, we have one question. If anybody else has a question, could you please post it on the chat? We probably have time for about 1 or 2 questions. So we have one question here. In nephrotic syndrome in pregnancy, what is the indication to start low molecular weight heparin for VTE prophylaxis? Do you take into consideration the proteinuria of more than 3.5 grams per day alone, or serum albumin as well?
Thank you for that question. That's a good question. We generally don't go based on the extent of the proteinuria, but we look at the serum albumin level. And that's because whilst we do expect a drop in the serum albumin based on the extent of urine protein, of the extent of the proteinuria, is a serum albumin that is most indicative of the woman's risk of VTE. So as I mentioned before, we tend to use a cutoff of serum albumin 20 here, and that's in grams per milliliter. And if a patient has a serum albumin of less than 20, we would often initiate Clexane or low molecular weight heparin. I hope that answers the question.
Thank you, madam. I think we'll go on to the next speaker in view of the time. Thank you very much, madam. I'd now like to invite Dr. Arun sir, who will talk about dialysis and obstetrician's guide. Sir is Chief Nephrologist of Department of Nephrology and Renal Transplantation at Vaidehi Super Specialty Hospital and at Bhagwan Mahavir Jain Hospital at Bangalore. He's also a consultant nephrologist at Kidney Care in Bangalore. Welcome, sir.
Thank you. Thank you, Dr. Prakash Mehta. Thank you, SMFM, for giving me this opportunity to share a few thoughts about dialysis in obstetrics. Hope the screen is visible.
It's not full screen, Dr. Arun.
Yeah, I'll do that full screen. That should be okay. Yeah.
Yes.
So, remembering Professor J.C.M. Shastri, my professor, he would always say the best way to make an audience understand is to tell them what you are going to tell them, and then tell them what you told them. So Dr. Renuka has already started the job of covering a part of what I wanted to speak. So now I'm going to tell you, and of course, in the panel discussion, we are going to again bring back these things and see to that you remember what we have told you today. This is something which I think preposterous of me to talk to gynecologists and obstetricians, but then I do take the liberty of putting this up. The anatomic changes that occur in pregnancy are evident by the 3rd month of gestation and persist till the almost 12-week postpartum. Okay, sorry. The kidney size increases significantly by almost 2 centimeters in length per kidney. There is increase in the vascular volume. There is increase in the interstitial space and the glomerular size. The greatest changes, of course, are seen in the collecting system, where the whole collecting system, right from the calyces up to the ureters, are dilated, including the bladder. The stasis of at least about 200 ml of urine occurs in the collecting system, and this, of course, leads to more changes, more problems of infection ascending into the kidneys, leading to pyelonephritis. And also, there is some changes that occur in the glomerular feedback, which is still unclear. It also changes the whole prostaglandin environment, and which in turn inhibits the normal flow of urine from the kidney to the bladder, leading to some amount of reflux. Also, there is hypomotility, there is stasis, and there is also the changes that occur due to the hormonal imbalances, leading to hypertrophy of the urinary tract, and of course, the mechanical obstruction caused by the enlarged uterus, to the extent of multiple syndromes being explained, where this can cause pressure both on the ureters as well as the vasculature. The functional renal changes that occur, the physiological changes, is increase in the cardiac output, and there is increased renal blood flow. The increase in renal blood flow in turn leads to increased GFR, and the systemic vasodilatation decreases the vascular resistance and decrease in the systemic blood pressure, as you are all aware. Why this is important is, when we consider any changes that we have to do with reference to dialysis, we have to consider these. And because what we consider as the dry weight for a person, that is the what weight we want to achieve for a patient post dialysis, and the amount of fluid we want to leave in a patient after dialysis, has to be closely monitored and tighter to the patient's fluid status, and cannot be used as it is, like we do for a regular patient. Similarly, blood pressures are a different level for a pregnant lady as compared to a patient on regular dialysis. In addition, the changes that occur to the whole milieu will lead to change in the various parameters, like creatinine, urea, uric acid clearance increases, and so the levels come down. You all know that serum creatinine and blood urea levels are lower in pregnancy, and we have to look for these, because what's normal for a normal person may not be normal for a lady with pregnancy. The same thing holds good with blood pressure also. We know that even small increases mean a large change that would have occurred in the physiology. And the urinary abnormalities tend to come up because of the increased GFR. There will be glucosuria, there will be amino aciduria, the water-soluble vitamins are excreted in excess, and the whole body is put into a extra tank of water, if I can call that, where the overall fluid status has gone up by about 6 to 8 liters. It's also important to remember this overall dilution as well as change in osmolality leads to a drop in sodium about 4 to 5 milliequivalents. And we should remember that when we look at sodiums of around 125 to 130, and you should not try to treat that. Sadly, I see a lot of patients getting excessive treatment for these kind of abnormalities in the biochemistries. This also leads to changes in the how ADH reaction, suppression of ADH occurs. So you know that the pregnant lady needs a bathroom close to her, and osmoreceptors are reset at a lower level to avoid the continuous diuresis, and plasma renin concentrations are 5 to 10 times greater in pregnancy, meaning to say that any fluid changes that you do have a much more bigger impact in a pregnant woman than in a normal individual. At the same time, there are opposite changes also. The pregnant lady is extremely resistant to angiotensin II. This probably may be because of the decreased sensitivity of the overall the tubular structures as well as the changes in the aminopeptidase levels, which can destroy the angiotensin II. There are also changes in the placenta, especially which is evident with the vitamin D3, but similar changes will also occur with the other hormones and prostaglandins in the body. So with this in mind, these are the various, a very simple way of putting of what can cause acute kidney injury in pregnancy. We know this in the first few weeks, it's the septic abortion, and then comes the abruptio placenta, hemorrhages, sepsis, then HELP syndrome, and the whole TMA associated mechanisms, and of course going on to the postpartum status where sepsis again comes back in our country, sadly. So to give a bigger list, of course, these lists can never be complete, and so right from hyperemesis gravidarum leading to a renal dysfunction to a severe sepsis or the whole intravascular coagulation pathway working up, leading and associated prone for the infections can lead to various acute kidney injury changes that we see in pregnant ladies. Of course, the obstruction and post-renal causes can also contribute, and sadly, sometimes we are even called in to see these patients. I still remember I was called in the middle of the night to call a patient who had not passed urine from almost 12 to 14 hours post delivery. So obviously the obstetrician was highly worried. And when I go there, all that I had to do was ask her to move her leg because the urinary tube was caught below her thigh, and she brought out about 1 liter of urine. So this may sometimes, looking back, be humorous, but causes a lot of tension both to the patient as well as the treating doctor. Even the incidence of acute kidney injury, of course, we know that age, admission factors, the condition in which the patient is admitted, the comorbidities the patient has, and socioeconomic factors contribute significantly to the overall incidence of acute kidney injury. In addition, there is enough data now to show that ethnic background also causes increased genetic and ethnic background has a significant role to play in a patient's proponents to have an acute kidney injury. So, without really going into the details of AK, indications for dialysis in pregnancy is dialysis should be initiated when the serum creatinine level is 3.5 milligrams per deciliter, because this roughly tells a GFR of less than 20 ml per minute. If you convert it into for a normal individual, it would say be about creatinine of about 5 or 6. So this I'm bringing in because I'm not really dependent on serum creatinine to decide on dialysis, because we know it's a very, very finicky molecule, and the levels can change variably. But we remember that even at lower levels of urea and creatinine, you may have to consider dialysis. Of course, presence of encephalopathy, presence of pericarditis due to uremia, there is evidence of neuropathy. This is especially true in long-standing patients. And volume overload, that's acute and chronic, which Dr. Renuka has already alluded to. And once there is volume overload and the urine output is not sufficient enough, and of course hyperkalemia and metabolic acidosis, acute or chronic, will have to be considered for dialysis. So what is important is, even in the presence of AK, a patient who needs dialysis is much more at risk of having problems than a patient who does not need dialysis. So this is all basically we are getting started. These are all from various registries, or this is looking back at the data. So many a time we may not have the exact follow-up of what happened to the patient, but still it is important to know that there is some amount of difference that occurs in a patient who goes into AK and needs dialysis as opposing to a patient who did not need dialysis and recovered from AK. So there is something which is much more than the severity of AK that precipitates the need for dialysis, and of course the presence of comorbidities always mean that there is a high propensity to need dialysis, and so presence of chronic kidney disease, presence of systemic lupus erythematosus also mean that there is higher incidence of needing dialysis. But at the same time, things like TMA have a almost similar incidence, but again, the mechanisms can be multiple, which we'll be discussing probably during the panel discussion. And any previous visit to doctors and nephrologists obviously will mean that there is an underlying kidney disease, and hence there is a higher this one. Age and the economic status do not have a major role in the need for going on to dialysis. The complications, yes, will be much more significant, and need for dialysis will be higher when there's a multifetal or a assisted conception, and presence of thrombotic microangiopathy or presence of any of the things that can precipitate AKI can always lead to the need for dialysis much more than a patient who is does not have these factors when the patient goes into AKI. But definitely it is a significant change because maternal mortality goes up with patients who need dialysis. And the other thing we are understanding now is we are recognizing AKI, but many a time it can be chronic kidney disease, which is picked up only when the patient presents to us with acute and chronic kidney disease. And sadly, if you look at the general population, almost 30% of patients who need dialysis due to AKI end up with continuing dialysis because they would have had a chronic kidney disease which was not recognized before. And perinatal outcomes are also worse when you consider patients who go on to dialysis. For that matter, the low birth weight is almost 5 times more. Chances are more in a patient who went on to dialysis. And the overall outcomes, including what are bad for the child as for the mother, including small for age and preterm births are much more common in patients who went on to dialysis. Something which is of a little interest to me, though I haven't gone through it too many times, is the pregnancy in a patient who is on dialysis. And more and more dialysis patients are getting pregnant and going through deliveries, though I haven't had too many opportunities. Only in 2 cases I've had the opportunity of delivering people who have had who are on dialysis. But the relationship between pregnancy and kidney disease, of course, all of you are aware of. What the pregnancy does to the kidneys, it worsens the ongoing renal problem. At the same time, once there is a kidney disease, the chance of pregnancy comes down because of infertility, abortion, preterm deliveries, IUGRs, and the preeclampsia syndrome that comes in. Why pregnancy in CKD is not possible is probably hyperprolactinemia caused because of the renal dysfunction. The LH levels are elevated, obviously reducing the chance of becoming pregnant. There is already a hypothalamic pituitary dysfunction, and early menopause is quite common in patients with ESRD. Anemia and various medications we use do not really help the cause. And depression because the body status and the dependence on dialysis, the ongoing disease status itself, a chronic disease milieu itself is not conducive for a good chance of developing, of having a pregnancy. But it is happening now. Why does it happen? Because we have improved the quality of dialysis significantly. We have improved the treatment of anemia, and rarely do we see people less than 8 grams of hemoglobin nowadays. There is change in counseling practices. More and more nephrologists and obstetricians have the guts to tell the patient, go ahead with dialysis, we'll back you up. And there is, as the general condition of the patients improve, as our supplementation of not only the renal function, but also the other changes that occur in the body help in improving the overall fertility of the patient on dialysis. So prior to 1976, there were no reported pregnancies in the registry, but it has slowly gone up by the end of last century. And in this, from the turn of the century, it has been going up. And this is data from 2016. There were about 616 pregnancies. This is basically Canada, USA data. And 7 out of 45 women receiving intensive dialysis. This is something which we are learning more and more. So if the patient wants to become pregnant, we have to change the dialysis regimen. Intensive dialysis can become pregnant. And peritoneal dialysis also, there have been reported cases, though the chance of pregnancy in a peritoneal dialysis is much less. Basically because there seems to be a little skew in the way we select patients for peritoneal dialysis. These are patients who are a little sicker than those who can go on to hemodialysis. And the other thing is the various solutions we use, which fills up the abdomen, can do changes to the motility of the ovum and can reduce the chance of fertility. The other thing that happens is even when patients on dialysis become pregnant, the diagnosis of pregnancy itself becomes a little tough because pregnancy is usually unexpected, and the symptoms of early phase, especially MSS and all that, will be similar to pregnancy itself, because all patients on dialysis tend to have some cause of vomiting and some nausea, which they may not attribute to pregnancy. And you can't diagnose with blood tests because beta HCG may be high even patients with chronic kidney disease, and many of them may not have a significant urine output to look for a pregnancy test also. So with this in mind, let us try to look at how we can contribute to dialysis in a pregnant lady. So hemodialysis and peritoneal dialysis both can be offered. There is no contraindication for peritoneal dialysis, but it wouldn't be the first choice, basically because of the needing to put a tube into the abdomen, which can increase the chance of miscarriage. But there are some conditions, like if the patient is not tolerating hemodialysis well, or we have access problems, or the hemodynamic changes, blood pressure drops become very significant during hemodialysis, we may opt for patients with pregnancy to go through peritoneal dialysis also. The maternal and fetal complications in dialysis are quite frequent, and anemia and blood pressure, we already know, are existent either in CKD or when there is acute kidney injuries. There is preeclampsia and HELLP syndrome. The chances go up, and both with AKI as well as already existing chronic kidney disease. Prematurity occurs in almost 80% of cases, and IUGR is not uncommon at all. Polyhydramnios and fetal distress does occur, and more than a quarter of the patients, of the children born, are underweight and below the expected growth. So how do we manage dialysis in a pregnant lady? So first, of course, is the discontinuation of tertogenic medications, including ARBs, ACE inhibitors. Low dose aspirin is recommended because there is a higher chance of developing preeclampsia, and there is a high chance of Down syndrome. So you may need to be much more proactive with trying to diagnose Down syndrome. So, but how do you manage dialysis in pregnancy? One would be adequate fetal monitoring, and the other thing is the preventing preterm birth, though both overlap a little. If the patient has a chronic kidney disease already on dialysis, you can still use indomethacin because you are not going to cause damage to the kidney any further. Use of corticosteroids, IV magnesium, and calcium channel blockers can help in preventing preterm births, and definitely monitor with umbilical artery Doppler every 2 weeks in a patient who is pregnant and on dialysis. The monitoring of cervical competency and amniotic fluid levels become important, and cervical incompetence appears to be more common in women with ESRD than compared to the general population. Circlage may be necessary, to prevent preterm delivery, and intensive hemodialysis is something which is found to be helpful. Try to achieve at least 38 weeks of pregnancy, and just presence of kidney disease doesn't mean that the patient has to undergo cesarean. Normal deliveries can occur if everything else is fine and the condition of the patient is fine. But remember, there is definitely significant compromise to the bone status, and be aware of that when you try to stretch the pelvis. And the newborn should always be managed in a high-risk unit, basically because the child's urea levels, without even with a good renal function, will be similar to that of the mothers. And as soon as delivery occurs, a severe osmotic diuresis can occur, and dehydration is a very, very significant chance that can occur in the newborn. And coming to the numbers themselves in the patient, when we dialyze a patient in pregnancy, try to keep the diastolic at least above 80. And because, as I told you, because of fluid status, I'm sure that all of you will think diastolic of 90 is hypertension, but then when you're dealing with dialysis, we need to keep it a little higher, because further lower means that you're causing a lot of decreased perfusion and target organ damage. And uteroplacental circulation has to be maintained. That means, say, the fluxes in fluid that we do when we dialyze should be minimized. And so the amount of fluid we remove and the speed with which we remove has to be controlled. And of course, be aware that this patient can develop preeclampsia at any stage. So how do we achieve this intensive hemodialysis? Already Dr. Renuka has alluded to this. It has to be at least more than 20 hours per week. And as we know that it's 4 hours thrice weekly for a regular patient, which is 12 hours, but you need to almost at least double it, and shift to night dialysis so that you can dialyze about 8 hours to 9 hours in the night. Target a blood urea nitrogen of less than 50, and decreases this. By doing this, we can decrease the incidence of preeclampsia and also polyhydramnios. There is growing evidence that intensive dialysis is definitely improving the outcomes. And with intensive dialysis, not only does it improve the chance of having a pregnancy, the overall outcomes also improve, and infantile survival of almost 75% can be achieved as compared to only 30 to 40% in the less dialyzed groups. And the mean gestational age has can be improved to almost 38 weeks, and nocturnal hemodialysis has much better outcomes. And so this is again the Canada USA data. So live birth rates have definitely improved 85% with intense dialysis. This is the number of hours of dialysis the patient gets, and these are the outcomes of the various this one. So with intense dialysis, the median birth weight has also gone up, almost reaching normal, though I would call it normal. And of course, median gestational age has gone up. So we are achieving 38 weeks plus in patients who have, this is the major change that has occurred with intensive hemodialysis. It is also important to remember to keep the potassium a little higher. For regular dialysis, we keep about 1.5 to 2, but here it has to be kept about 3.5 milliequivalent so that there is no hypokalemia. Bicarbonate has to be improved. Stop the phosphate binders because we are doing intense dialysis, so phosphate binders may not be necessary. Use a higher calcium in the dialysate because we tend to use lower calciums, and improving it to at least 2.5 plus give additional calcium orally, and keep sodium slightly on the lower side because as we know that the osmolality levels are slightly low, though we keep about 140 in regular dialysis. And the type of dialyzers we use also has to change. We have to use a low flux dialysis because it's going to be a long-term dialysis. So the duration is going to be long. Use a low flux dialysis. Reduce the amount of fluid you remove because anyway you're dialyzing them daily. So you can afford to leave them a little. Plus, avoid hypotension at any cost. As I told you, keep a little higher diastolic. Prevent target organ ischemia. Avoid any abrupt osmolality changes, and use high surface area membranes with lower flows so that you achieve better results. So these are the major things which contribute to changes in the amount of dialysis you can do. That is the type of membrane you use, the surface area of membrane you use, the pore size of the membrane you use. These are the changes which we have to keep in mind when we dialyze the patient. And even the blood flow don't go suddenly. We increase the blood flow rates. We generally tend to increase it over 10 minutes in patients on regular dialysis. Try to keep it slowly. So bring it up to 300 ml per minute over 30 minutes. And the dialysis flow can also be controlled with the newer machines. Use a lower dialysis flow so the dialysis is more gentle and the exchanges that occur are not very steep. The use of heparin, of course, has to be monitored very closely. The need for heparin goes up because we know pregnancy is a hypercoagulable state, but at the same time, we are always worried about vaginal bleeding. And if you are talking of a chronic kidney disease patient, you already know that the patient is prone for bleeding. But with more and more use of low molecular weight heparin, which helps not only in the pregnancy outcomes, but also it helps us a lot in maintaining dialysis anticoagulation. Of course, supplementing protein, at least 1.5 to 2 grams per day per kg is essential. Carbohydrate has to be supplemented, and a deficiency for especially iron has to be looked at. Folic acid supplementation becomes necessary. We should remember that all the water-soluble vitamins will be lost in dialysis. We know they will already be lost in a normal pregnant woman, so supplementation becomes all the more important. Assessment of the dry body weight, as I told you, was important, and allow for normal pregnancy weight changes that occur. So 1 to 2 kgs during the first 3 months and 0.5 kg a week during the rest of pregnancy has to be maintained. Just don't go by the fluid and try to remove too much of fluid. And hematocrit and albumin levels are an easy measure of the overall fluid status of the individual and can be monitored accordingly. Anemia, of course, has to be corrected. 10 to 11 grams per deciliter erythropoietin. See to that there is no iron or any contributing factor deficiency, and weekly monitoring of the hemoglobin and the other parameters of hematocrit. The hemodialysis prescription should also include a left lateral decubitus position because the changes in blood pressure will be minimal, and so achieving, though it becomes difficult for somebody to lie down in this position for such a long time, but try to make them comfortable in this position. And if there is any change in blood pressure, try to bring them back to this position so that the returns to the heart improve and the blood pressure improves. If worried about postpartum patient on dialysis, there is no contraindication, can definitely be fed, but chances of having maternal milk is definitely much less. But if there is sufficient maternal milk, and to minimize the various toxins that can enter the baby, continue the intensive dialysis and try to feed the baby after the dialysis is over. And then, of course, the drugs, which I'm sure you will all be aware of, to restart the drugs which we had stopped and which can be helpful after this one. But depending on the breastfeeding practices, you may have to use the drugs with enough care. So in summary, so medication management includes discontinuing teratogenic drugs and giving higher dose of vitamins. The dialysis prescription includes intensive dialysis, wherein the hours of dialysis have to be increased. A slower, gentle, longer, and much more comfortable dialysis becomes important. Adjusting the potassiums, calciums, and other magnesium, like other minerals, becomes very important. Blood pressure goals should be tighter to the patient and the pre-existing disease the patient has. Correction of anemia, we have a lot of options: better ions, better erythropoietin, and see to that the diet is adequate. Fetal surveillance every second weekly is a must, and postpartum, when the child has to get into the high-risk care unit, and breastfeeding, if possible, should be allowed. And of course, supporting emotionally the woman becomes very, very important. So to conclude, it's customary for me to quote a famous Kannada poet D.V. Gundappa, who is almost a saint poet in Kannada literature, who describes the jasmine in the forest. ಕಾನನದಿ ಮಲ್ಲಿಗೆಯು ಮೌನದಿಂಬೆರಿದು ನಿಜ ಸೌರಭವ ಸೂಸಿ ನಲವೆಂ ತಾನೆಲೆಯ ಪಿಂತಿರ್ದು ದೀನತೆಯ ತೋರಿ ಅಭಿಮಾನವನ್ನು ತೊರೆದು ಕೃತಕೃತ್ಯತೆ ಪಡೆವಂತೆ. The small jasmine flower in the forest hides behind the foliage, and only when the jasmine flower dies does the rotting smell of the forest come up to you. Similarly, without the beat of the heart, without the reflex of the nerves, without the size of the liver, the kidneys function continually without even knowing that they exist. But only when they fail does the uremic smell spread all around. Let us do our best to prevent this uremic smell from spreading. Thank you.
Thank you very much, sir, for the detailed enumeration of dialysis in pregnancy. It was
Thank
an
you, Dr.
exhaustive
Arun.
discussion. Yeah,
Dr. Arun is one of the most sought after nephrologists in the city. And of course, he has been my nephrologist for the more than last 2 decades. But I always consider him my enemy. You know why? Because he sent me all those CKDs with pregnancy. And by the time I deliver them, I age by at least another 5 years. They ooze, they bleed, they give you a lot of trouble. And even every time I've done a cesarean or a normal delivery on a CKD patient, that night's sleep is definitely gone. So that's how the kidney disorders affect the pregnancies. But well, he's a savior also, because a lot of our AKIs have definitely been saved courtesy him. That's why I would request that everyone need to have a good nephrologist on their team if they're handling severe preeclampsias.
And like Sir said, Arun Sir said during his slides that a multidisciplinary approach with obstetricians and nephrologists together, they can do very well in saving lives. All right. Sir, we will get back to you with the panel, sir, Arun sir.
Yeah, sure.
Now we'll move on to the launch that we have today, for which we have representation from the SMFMI leadership, Dr. Prakash Mehta, sir, and Dr. Revati, madam. And from the iShip leadership, we have Professor Anne Mary, ma'am, and Professor Surosh Rana with us. First, I'd like to introduce Dr. Prakash Mehta, sir. He's the Chief, Department of Maternal Fetal Medicine, Bhagwan Mahavir Jain Hospital, Bengaluru, President of the SMFMI, Indian Co-Chair for Preeclampsia Education of the Nation, India, that is PEN-I, Organizing Chairperson of iShip World Congress 2023, so has contributed numerous articles in various journals, contributed to chapters on maternal fetal medicine in many books, and delivered oration in the field of maternal fetal medicine at various places. And Sir is everyone's favorite. Then I'd also like to introduce Dr. Revati. Revati madam is Chief Consultant and Managing Director in Meda Health, Basveshwanagar, Bengaluru. Madam is Secretary of SMFMI. She's the Indian Co-Chair of PEN-I, Organizing Secretary at iShip World Congress 2023 held in Bengaluru last year. She's now nominated the International Co-Chair for iShip 2025 to be held in Chicago next year. She has many awards and publications to her credit. Thank you for being with us, madam. Professor Dr. Anne Mary, madam. It's a great privilege to welcome Professor Anne Mary, ma'am, who's the president of iShip. She's a dean at the Western Sydney University. Madam excels in women's health research. Madam has several publications to her credit and done several presentations. Preeclampsia and medical education are her areas of interest. Dr. Professor Surosh Rana, ma'am, is here with us today. I now welcome her she is the Professor of Obstetrics and Gynecology, Chief of Maternal Fetal Medicine at University of Chicago, Global Co-Chair of iShip, Global Co-Chair for PEN-I, International Advisor for the Society of Maternal Fetal Medicine, India. Madam has several publications and done several presentations. Madam has joined us now from USA, almost running into midnight. Thank you, madam, for being with us. I request Dr. Prakash Mehta, sir, to say a few words and launch the course. Over to you, sir.
Good morning, all, once again. It is indeed a pleasure to release this program. This is the first time that a program is being offered free to all the Penai delegates. It contains a lot of information from the iShip 2023 World Congress. Uh, I have to credit Dr. Revati because my job has just been to mentor. All the hard work has been done by Revati to bring this program into reality. And of course, we have had the backing of Dr. Sarosh and Dr. Anne Mary, who are always with us. And, we thought that iShip 2023 World Congress lectures were a class unto themselves. And we thought that if we could give it to our delegates, we are very sure that the management of pre-eclamptic women would change, and we would definitely save at least a few women across India by doing this program. So I now request Dr. Sarosh Rana to say a few words regarding this.
Hello, thank you so much. It's so nice to see everyone. Actually, I was talking to Revati just a few days ago, I think yesterday. She's going to help me with the next Congress. But yes, this is amazing. Thank you. I'm very happy actually because I agree. It was a lot of actually most of the work was done by Revati to get that MOU, whatever we are stuck with signing that. So now we finally have these lectures. I think that'll be great. And I'm so happy. I was just wondering how many delegates we have now for Penai. There must be a few hundreds now.
Yeah, I think 400, 600 and odd, isn't it, Revati?
650 delegates, sir, and
That's
400.
amazing.
I
And
think
another
450
800
plus,
delegates will be
45.
joining in the course of next few months because we are coming
That's
up with zonal
great.
conferences.
Yeah, and I think that's great. So I think we obviously keep these lectures from 2023, but I think there are so many things that we learned from the 2023 conference. Is one, I was telling Revati that I'm gonna make a proposal to the iShip that we keep the previous chair as the co-chair for the next conference. So, for example, Revati was the chair in India, so she can serve as the co-chair when I hold the meeting, because I think there's just so much knowledge that is already existing that can be transferred. And perhaps we can do this every 2-3 years, Revati, that once we have these conferences, and I don't know if we'll be able, we should propose that we record all of 2025 lectures as well. And then we can keep updating our deck of slides that we are attaching to Penai. So we are not like super behind in terms of what information we are passing on as part of Penai. So I think we can do some of these things since you guys are also part of the executive committee. So we can formally propose this to the iShip leadership, which is mostly me and but other people too, to say that we should have these available. I think this will be a great resource for people. They can watch it at their own time. They can use these lectures to, make their own presentations, teaching other doctors, residents, whosoever is coming along. So I think this is great.
Right. Thank you, Dr. Sarosh. I think Dr. Anne Mary is held up with something. She's not joined, if I'm not wrong.
Yeah, I was looking for her. I don't see her.
Yeah, I don't see her. That's what.
That's okay.
Okay, so we go ahead and inaugurate this particular program. Yeah, thank you. And I request all those delegates who are attending or seeing this program on YouTube to make sure that they become Penai delegates, Penai certificate holders. They will definitely get this program absolutely free. And
so I have a few questions.
Sorry?
I just had a couple of questions.
Sure.
Logistical questions. So all those people who have already registered and been obviously being registered for so many past years, you have their email, so you'll just pass this along to them. Is that the
Yes,
plan?
absolutely. We have all the data with us, and they are invited to most of the programs.
Okay. And then Revati, how many hours of lectures do you have in here?
33 hours, Dr. Sarosh.
Which is
That's
amazing.
massive.
I mean, yeah. And are they collated like by subject matter or by authors? How did you collate them?
By the categories, like we've put them as lectures, plenaries, workshops, and oral presentations. And they also get to
And
visualize the slides.
no, sure. And then can the people search them by like name of the professors, or it's only by the topic?
By the categories.
Category. If they say
Okay.
plenary, they get all the plenaries.
So
And they will be allowed to access it for 2 weeks. After that, the program will self-destroy.
that is just to
Oh,
motivate them to make sure that they have the momentum to read it. It shouldn't be like in the archives for a long time. Suppose somebody requests us, then we would extend the access.
okay. And then, but you will have the archive for all the lectures, like
Yes,
in
we
our
give them coupons.
SMFMI. Yeah,
Yes.
in our thing. Yeah, I agree with that. Okay, that's great.
It was a huge program, but somehow we could pull it off.
Yes.
Yeah, I
Thank
think this
God.
is like there's so many
Because we had to
lessons.
get permission from all the
I
speakers.
know, that's okay. I think
So
this is like, yeah, we will see how popular it is. So I think perhaps there may be some benefit in asking your delegates if they really liked it. And if they did, then we should, I think, Revati, you and me going forward, we should propose some of these things which we really think are helping you. Maybe this will help, I don't know, people in Brazil as well. So I think if you get good feedback from your delegates that they listened to it and it was helpful for them for future
Yes.
information, like above and beyond the Penai lectures, then I think we should propose some of these things formally to iShip so they can make this a thing. Like maybe every 2 years, whenever we have an in-person meeting, we should record these and make it available to societies like yours, like SMFMI. Like if we have Penai, maybe there are other people in, I don't know, in the world, maybe they're trying to teach. So maybe iShip can make these lectures available to them as well. That could be something, Revati, I don't know if you want to like take on as the co-chair for the 2025 to ask other country people if they would be interested in getting this, kind of 33 hours of lecture is a lot of hours of lecture. But get some feedback quickly from the
Sure.
delegates and see if they
Yes.
find this cumbersome or it was kind of fun to listen to it. I think that'll be good to have too.
Sure. We'll design a feedback.
no,
And
add a feedback form
Mm.
to that program, Revati. That's it.
sure,
Yeah,
we'll do
just
that.
even
We'll
like
do it.
2 questions. Did they find it helpful or not? Because we don't
Yes.
want to do all this effort again. I mean, obviously, this is a lot of
Yes.
effort right now, but if it's helpful, then I think we should do it. But if people say, no, your lectures are great, we don't want more lectures, then we'll be like, okay, fine. But I think it's a great resource.
Sure. We'll do that.
Yes, Akshita, please go ahead.
I thank all the leadership from SMFMI and iShip, Dr. Prakash Mehta, Dr. Revati, and Professor Sadosh Rana, Madam, to have launched this for the benefit of the registrants with the course content. Now I request Dr. Revati to give an update on the Penai program.
Thank you so much, Akshita. And good morning, everyone. And it just gives me great privilege to be presenting what we're doing at Penai. Next slide, Chitrakala. As we are all aware, this is a program that started in way back in 2021, and this is a collaborative project between the Society for Maternal Fetal Medicine India and the International Society of Study of Hypertension and Pregnancy. So we have the global co-chair, who's Dr. Sarosh Rana, who's with us. We have Dr. Prakash Mehta, who is the Indian co-chair, along with myself. Now, I just want to emphasize on what Penai is doing. We started this Penai online series. Previous slide, please. Yes, this was in 2021, which kind of recruited people only for online certification. We then added on the VLS PE program. This was again on the World Preeclampsia Day 2022. So this was to give dedicated information on specific topics, and this was absolutely free. And this was also top-up information for all the Penai registrants. We then moved on to have the on-site and on-campus versions at request by medical colleges and different societies. So we went to their campuses and we ran the program on-site because they wanted to do group learning and certified them on-site with a pre-test and a post-test module. Then we got the World Congress here, and that was a very, very important landmark for us because that was a lot of learning for all those who wanted to improvise or who wanted to collaborate regarding hypertensive disorders in pregnancy, present their projects, and kind of build associations with so many faculty from around the world. We had about 294 registrants who actually participated from across the world. And we also had a lot of students who actually participated as volunteers. So the total number of attendees were about 420. Then we moved on. After the iShip World Congress, for the recordings of which is going to be provided to all our PNI registrants, we moved on to have a state level workshop. This is the first ever workshop at Trichy. We had something like about 150 participants who actually certified for PNI. That was again a landmark event because we were doing it on site at a state level in the country. Then we went on to certify people from different societies, like for instance, the Hubli, Dharwad, Davangere in Karnataka, Madurai in Tamil Nadu. We also moved on to the corporate wing because we thought we should not be differentiating anybody who asked for it. We gave it to everybody, the private practitioners, the medical college people, the societies, everyone. So, and the iShip World Congress, in fact, involved the nurses and other care providers because it's ultimately everybody should know. We also included the patients. So, ultimately, we had the doctors, the nurses, the patients. We had multidisciplinary specialists all talking about preeclampsia, learning and updating themselves. We also have been collecting feedbacks, and I'm sure most of these people are also posting clinical questions on our virtual interactive sessions. They're also been sending messages to us on WhatsApp as well as on emails if they have a difficult case, and we are trying to solve this real time. The next important thing that PNI is going to do is to have a zonal online certification process. So it's going to be about 5 hours of learning packaged on maybe a Sunday or a Saturday. So we have about 150 to 200 clinicians zone-wise, north, south, east, west. We're starting with the south zone, which is probably going to happen on the 29th of December. There's a lot of enthusiasm from the delegates to participate after the World Congress. So we are going to give them about 8 lectures and then, pre-test, post-test, certify them, take their feedbacks and put them into our archive, in our connect list so that we can communicate with them regarding our extended academics. We have already launched the iShip World Congress proceedings, the scientific proceedings. This can be accessed by all our PNI delegates as a step-up information. We have been giving PNI courses to Bangladesh, Afghanistan. There have been requests from Kazakhstan. Recently, I had a talk, an online talk with the Kazakhstan Society, and they're very, very interested to take this to their country. So we want to move on to other countries like Brazil and other countries as well, like what Dr. Sarulfana spoke. And ultimately, what we want to do is endpoint certification followed by updation in all formats. We want everybody to learn about preeclampsia, clinicians, nurses, paramedics, patients. We also have a textbook which is shaping in very well. We had a soft launch at Sydney. We are trying to launch it at our SMFMI meeting. It's been 18 months of editing. We have 80 chapters, and we have about 147 authors in this book who have written about preeclampsia. We have the Suraksha PE program for the patients, which is shaping up. So all this is kind of the momentum that PNI has actually created. Next slide, please. So we have about 625 registrants, 439 past candidates who are certified. We are also looking at the 156 who couldn't clear the post-test. We're trying to have a viva, trying to ask them clinical questions and trying to certify them so that they are kind of empowered. So we have about 110 online. On-site is about 515, which is popular. We have all these societies, Mysuru, Rajarajeshwari Medical College in Bangalore, Baptist Hospital in Bengaluru. We have the state level conference, Madurai, Hubli Dharwad, Ovum Hospital, Tirunelveli. Here you can see that we've actually participated in different categories. We've involved the societies, the medical colleges, the corporates, and everybody, as part of this PNI program. So I think I've already discussed about the different updates that we want to do. We also plan to do PEN South Asia. We're trying to work it up. We're trying to probably go to Nepal and other countries, Sri Lanka and other countries where we probably want to make this, popular there. So this is all in the books. Next slide, please. Yes, so we also have this regular virtual interactive sessions for our certified delegates. So they participate in asking questions, and the coaches actually answer real time. So these are real problems that they're facing in the OPD. It's not in the books, it's not in the papers, it's real time. And it makes a huge difference. We've been getting a lot of feedback, and a lot of clinicians have changed their management based on the discussion. So that's very, very satisfying. We've had representations from across the country. Next slide, please. Yes. Next slide, previous slide, please. So the pilot project of PEN, next slide, yes. So okay, so we have the workshops, the zonal versions are in, the global is set, and we are open to having workshops in any of the different societies or medical colleges of the country. Please send us an email and we will try to fix it up. We could do it online, we could do it on site. The whole idea is to spread preeclampsia education across the country. Next slide, please. Yes, the pilot project is closed with 250 certified delegates. We want to put in all this data into a structured paper so that, probably this could kind of get other collaborators work as well on this, on these lines. And we want to put it into a reputed journal. Next slide, please. Yes, so this is about our recent course. So this is going to be available on our website. We are going to give coupons to institutions so that every institution would be given a dedicated time to access. And we would also collect feedbacks. We would also put them into our connect lists so that we would keep them updated about future academics regarding the SMFI as well as PEN. Thank you so much.
Thank you. Thank you,
Thank you,
Revati,
Revati.
madam.
And I take this opportunity to invite all delegates to our annual SMFMI Day conference, which is planned on March 23, 2025. This is the day that our book on hypertension is going to be released, and we are going to have an oration and a whole lot of academic feast on that day. Please mark your date. You will get more information over a period of time.
Thank you very much, sir. Save the date, 23rd March 2025. Fine. Thank you, Revati madam, about the update on PENI. And I now request Dr. Prakash Mehta, sir, to take over the stage for panel discussions as moderator. And I invite all our esteemed panelists to be on call and discuss about renal consideration and complications in preeclampsia spectrum. The panelists with us are Dr. Bharti madam, who is an assistant professor, Department of Obstetrics Gynecology at PGI Chandigarh. Madam's areas of interest include high-risk obstetrics, perinatology, especially stillbirths. And Madam is also a regional trainer for MPDSR and establishing newborn birth defect and stillbirth surveillance. Madam has many publications in several national and international journals. Welcome, Bharti Madam. Then we have Dr. Malini Madam with us. She's a consultant maternal fetal medicine at Fernandez Hospital, Hyderabad. Her areas of interest being cardio-obstetrics, hemodynamics, and preeclampsia. Madam has been instrumental in setting up protocols for high-risk pregnancies. Welcome, Malini Madam. Then we have Dr. Sushma Madhuprakash, who is a consultant in maternal and fetal medicine at Dr. Jyoti's Healthcare Private Limited, Mysore. She's an executive committee member of SMFMI, and Madam is a concept builder in PENI initiative. And her areas of interest include in utero, fetal programming, and medical disorders in pregnancy. Welcome, Madam. Then we have Dr. Arun sir, nephrologist for the panel. Welcome again, sir. Sir, Prakash Mehta sir, please take over.
Sure. Thank you and welcome to all the panelists. Okay, our panel today is going to be on kidney and preeclampsia, the renal considerations and the complications. And I've got a whole lot of faculty with me, all experts, all managing high-risk pregnant patients and across India. Now, I'm sure all of you recognize her. This is Smita Patel, a famous actress. And I put a picture because she died at a young age due to renal failure because of preeclampsia. Possibly it was a HELP syndrome and she lost her life to it. So when we talk of kidney and preeclampsia, we have two aspects, the effect of preeclampsia on the kidney and the effect of kidney on preeclampsia. Now, before going ahead, although partly covered, let us understand the physiological and anatomical changes in the kidney during pregnancy. Now, why is this important? Because unless you understand what changes have occurred, it is very difficult to identify a pathophysiology that occurs during pregnancy. So the first question goes to Dr. Bharti. What are the anatomical changes that occur in pregnancy?
Thank you, sir. So basically, these are very beautifully elaborated by Dr. Arun, but I would like to highlight here as an obstetrician, we just remember two things, that there will be increase in kidney size and there will be dilatation of pelvic calyceal system. So always remember these changes can start as soon as the conception occurs. So it has been seen that these changes start as early as by 6 weeks of gestation, and these changes are more towards the right side. So it is very important to interpret the ultrasound finding if someone has reported it's a hydrouretronephrosis or something like that. So we need to remember some changes are physiological. That is the only important point. Thank you, sir.
Thank you. And the next question goes to Dr. Malini. What are the changes that occur in renal function during pregnancy?
This question also has been answered by Dr. Arun, but then again, I would like to go through it for the benefit of the attendees. So we all have been studying that there is an increase in the glomerular filtration rate by almost 50%, increase in the renal plasma flow by more than 80%. And as Dr. Bharati said, these changes start very early, as early as 6 to 8 weeks. But what are the physiological implications in pregnancy? And why is there an increase in the GFR? Increase in the GFR and renal plasma flow is mainly because of the reduced vascular responsiveness to these vasopressors like angiotensin 2 or arginine vasopressin. So because of the increased GFR, what changes do we see in the renal parameters? There is a decrease in serum creatinine. So any creatinine more than 0.8 milligram per deciliter in pregnancy should be considered as abnormal. And there is also increased proteinuria. What we take as 100 milligram per day or 150 milligram per day in the non-pregnant state, the proteinuria increases to 300 milligram per day during pregnancy. There is also increased glycosuria in pregnancy. So we cannot use a urine dipstick to detect diabetes during pregnancy. And there are changes in the acid-base balance as well. Because of the respiratory alkalosis or due to the progesterone effect, the kidney compensates by excreting more bicarbonate. So the bicarbonate levels in ABGs were 18 to 22 should be taken as normal rather than 26 in the non-pregnant state. Because of the low bicarbonate, we see that the pregnant woman does not have much of the buffering capacity, so she is more prone for acidosis in case of any insult. And also there is a osmotic reset of the osmostat, so there is decreased osmolality. And also the serum sodium levels, they fall by almost 5 milliequivalent. So 130 should be taken as normal during pregnancy.
Yeah, thank you, Dr. Malini. And I think you brought out a very important point that the serum creatinine 0.8 should be considered as upper normal. What happens, what has been my experience is that, when most of the obstetricians see the lab report, the normal there is marked as 1.2 milligram. Unfortunately, we don't have any lab printing normal for pregnancy. And, either the answer is not boldened or not in red color in a busy OPD. You look at that report and tend to miss it. Please note that any value above 0.8 milligram of creat is to be considered as abnormal in pregnancy. So with this, we'll go to the case. This was a 22-year-old gravida 2 paraben living 0. She had a history of severe preeclampsia during her first pregnancy, resulting in a cesarean section at 28 weeks and delivery of a dead 800-gram baby. The current pregnancy was uneventful, except for some mild preeclampsia coming in later, and a little bit of fetal growth restriction was also identified. At 36 weeks, the non-stress test was non-reactive. Hence, the patient was taken up for a cesarean section. She was a previous C-section, BOH, so she was taken up for a C-section. Blood pressure at this time of surgery was not too great. There was only mild pedal edema and 1+ albuminuria. She delivered a 2.4 kg baby, which did very well in the neonatal period. The surgery was otherwise uneventful, did not expect any problems with her. About 9 hours after surgery, a decreased urine output was noted, which did not respond to fluid challenge. So this question goes to Sushma. Sushma, what do you think happened to this patient? Sushma?
Sir?
Sushma, are you there?
Am I audible, sir?
Yeah, now you're audible.
Okay. This is a case of severe PE with acute kidney injury, sir.
Okay.
And I would like to know about our other parameters, sir, like her blood parameters, sir. That was not told here.
Yeah, by the time we got the blood parameters, of course, the creat was high at that particular time. But she was absolutely eventless for 9 hours after surgery, and the surgery was also uneventful. So this case basically I presented to point out that how changes could occur over a period of few hours, number one. Number two, remember that most of the severe preeclampsias worsen after delivery.
After
So you
delivery.
may have nothing before pregnancy, nothing at the time of delivery, but in the post-delivery period, you could have issues.
Yes, sir. So this is a case of because the creat
Absolutely,
is
of HELLP
raising, it's
syndrome.
yes, sir, HELLP syndrome with the AKI.
So this was the patient who ultimately went on a ventilator. Her RBC showed a typical picture of cystocytes and bullet cells and all kinds of things. She did have a lot of ecchymosis coming in over her body. So before we go further, Sushma, what is fluid challenge?
Fluid challenge is it involves giving a large bolus of fluid, approximately around 500 ml of normal saline over 15 to 20 minutes, and watch for her BP, increase in BP or urine output. And if in case if the BP is at a normal range, Lasix challenge can also be given of 10 to 20 mg following the bolus to see for the response, the kidney response.
Okay, so depending on, you give her a bolus of fluid and see if her urine output increases. If not, there is possibility that we are dealing with an AKI.
And also to look for if there is preeclampsia, the ventricles are not that compliant. So there should be a caution advised while giving a fluid bolus in such patients to look for pulmonary edema also.
Right. So about 12 hours after cesarean section, there was no urine output. AKI was considered middle of the night. One SOS was sent to Arun that there is no urine output. What do we do now? And platelet count and liver enzymes are ordered. The platelets are only 30,000 and the AST-ALT range was very, very high. There was hemolysis. The hemoglobin dropped from her 11 grams. She dropped drastically in her hemoglobin. Of course, a diagnosis of HELLP syndrome with renal failure and liver necrosis was made. And in the next few hours, patient developed subconjunctival hemorrhage and had a bout of bleeding also per vaginal. So with this, we get in Dr. Arun now. What is AKI? I know you have covered it partially, but we would like to tell that in more simpler terms so that every obstetrician understands.
It's a very interesting the way you have put the case across, because these are the challenges when we diagnose AKI. Now, this patient didn't have much blood pressure. She was very stable throughout her anesthesia, and then she comes out and suddenly she becomes anuric, hypotensive, not breathing well, etc., etc. So, what exactly is this? Is this pre-renal? Did you dry her out too much? Is she bleeding somewhere? Or does she have any cause of sepsis that has come in because she has just undergone surgery? She was in a postpartum state where she can have sepsis. So all these questions come in. So we have to remember that abnormalities to the biochemistry and the other parameters take time to come in. So if I had seen her probably 3-4 hours later, there wouldn't have been a doubt of any AKI coming in here at all. But by 6 hours, she is already sick. And by the time we get the reports, another 1 hour, and you see that there is a huge amount, almost a storm of intravascular coagulative pathway has been initiated. So these are the challenges which come up when we look at AKI. So depending on creatinine or depending on other things will be difficult. So first look at first look at urine output, and now we depend more and more on urine output. And if the urine output starts falling, don't look at all the 0.3, 0.2s, 0.4s. It is less than 20 to 30 ml per hour, then you know you are in trouble. And involve the nephrologist much early on, so that you are prepared to see whatever, because it can be a bleed, it can be a TMA that is coming in. So you should be willing to handle both these and keep the blood bank always informed. And AKI is not uncommon, think of it, but such a severe case causing AKI, thankfully, is not that common. But there were clues in her, she had severe PET before, so be ready for that.
Absolutely. So once the AKI comes in, the chances of maternal mortality increases exponentially. Dr. Bharti, what are the causes for AKI in obstetrics?
Sir, like in a general population, even in obstetric, we can divide the causes like pre-renal, renal, and post-renal. But we usually go by gestational age, because as an obstetrician, so in first trimester, the most common cause is can be like hyperemesis, severe hyperemesis, or women can present with ectopic pregnancy or acute hemorrhage, or a spontaneous abortion with bleeding excessively, or it can be a septic abortion nowadays. Although we come across very less patients of septic abortions, then pregnancy specific conditions are most common in second and third trimester, like preeclampsia, HELLP syndrome, acute fatty liver of pregnancy. Then we come across these thrombotic like TTP, or in postpartum we usually come across these atypical HUS or TTP. And these obstructive causes are also common in third trimester. And sepsis is another cause which we come across postpartum patients. So these are the common causes of acute kidney failure in pregnancy.
Yes, also just please don't forget that an amniotic fluid embolism can present like a renal failure for the first time. You should never forget that, because amniotic fluid is like a chameleon. It can present with any kind of symptoms. You may not have breathlessness, you may not have DIC, but you may have a AKI. So keep that picture always in mind.
Yes.
Okay, another one small thing that we should never forget is, I've seen many of the pre-eclamptic patients being given, NSAIDs. Please avoid NSAIDs in preeclampsia because they can precipitate renal failure. So be careful about them. Now, next question to Dr. Arun. We have ATN, we have acute cortical necrosis. What are they? Why are they? What is the difference between the two? And what is the difference in prognosis for the two?
Yeah, it is very intriguing that the same set of problems, hypotension, sepsis, can give rise to such greatly different outcomes, which is acute kidney injury on one end, for all practical purposes, ATN. It can also be acute interstitial nephritis, and at the other end, acute cortical necrosis. 80% of acute cortical necrosis occurs during pregnancy and 20% otherwise. So there is something that is different in the pregnant woman than the others, which contributes to this change. So probably the prostaglandin imbalance, especially the endothelin, is what causes the change. And there is a huge set of things that occur, including decreased blood supply, which is associated with the thrombotic changes that occur, and acute tubular necrosis, thankfully, is reversible. And who will undergo ATN and who will go on to acute cortical necrosis is very difficult to say. But once there is sepsis, once there is the associated significant PET or TMA, the chance of acute cortical necrosis is much higher as compared to ATN. And thankfully, it has come down significantly now.
Yeah, thank you, Dr. Arun. So that was a little enlightening about the difference between the two. Dr. Malini, just in short, what is the natural history of the progression of the disease?
Acute kidney injury is said to progress in 4 stages. First is the onset or the initiation of the insult. then the stage of oliguria or anuria, depending upon the extent or the degree of injury, whether it is transient or prolonged, where where we see the clinical features of reduced urine output. We have to be careful at this stage not to volume overload the patient, since the kidneys are shut down. It may precipitate a pulmonary edema or even cardiac failure. The third is the phase of recovery, which you usually see after a week or so, depending upon again the duration or extent of the insult. Here, there is increased. I mean, the output is more. There is the renal tubular reabsorption of the water and electrolytes is lost. So there is a lot of high volume urine output, as well as the patient loses a lot of electrolytes. Again, there will be dysalktolemia, and they should be managed with good input output and electrolyte monitoring. And then comes the phase of restitution or the recovery. So if you look at the natural history, it can the AKI can resolve completely or progress onto CKD, or it can be acute kidney injury on CKD or progress onto end-stage renal disease. That is my understanding as an obstetrician.
No, perfect. Because what happens is, we tend to, once the urine starts coming, we tend to go a little lax. But please remember that when there is a diuretic stage, she could still give you problems, and be careful about her. What are the various ways to classify and stage AKI, Dr. Arun?
It has been a tough job, and really there is no satisfactory classification of staging AKI. We are dependent on what is told in the general population, that is the Rifle criteria, which basically stands for risk, injury, failure, loss, and finally end-stage renal disease. Sadly, in the non-pregnant population, almost 30% of patients who go on to dialysis with acute kidney injury tend to continue on dialysis, probably meaning we may not have picked up a pre-existing disease, or there has already been significant damage. But what is much more relevant to us is how to diagnose this AKI, which is dependent on what is known as AKI criteria or Akin criteria, which depends on the urine output. Though there is a small variation in the numbers, as I told you, it is about 0.5 milligrams per kg per hour, and then going on to less than anuric phase, which is less than 0.3 ml per kg per hour, is what we call the AKI network criteria. But these two help in understanding that there's already underlying renal disease, and don't depend on creatinine, don't depend on urea. Looking at urine output, please make a diagnosis. Of course, if things like acidosis, hyperkalemia, pulmonary edema, etc. come in, things become easy for you to make a decision that there is something ongoing. But with better access to investigations, we are able to diagnose things earlier. But still, sadly, to diagnose renal dysfunction, there is only one simple test, that is looking at the urometer and measuring a proper intake output chart.
Yeah, very well put, Dr. Arun, that there is only one test, looking at the urinometer. And I think it is also a wake-up call for all the maternal fetal medicine people to make sure that we come up with some kind of a algorithm for these patients, because what we are dependent on is all non-pregnant patients. Okay, the next question to Dr. Malini: what is the renal pathology seen in preeclampsia?
In preeclampsia, the pathognomonic finding is the renal glomerular capillary endotheliosis. That is the swelling in the glomeruli, which we see on a slide as enlarged and bloodless, and the glomerular capillary lumen is narrowed. This leads to a decrease in the GFR and the renal plasma flow by almost 30% as compared to pregnancies without preeclampsia. And there is also a podocyte damage. The podocytes are the cells that line the glomerular basement membrane, and they form the charge and size barrier that is called the slit membrane. So there is a damage to these podocytes. The podocyturia, that is the live podocytes, are seen in the urine, though it is not yet standardized as a marker, but these are seen in early stages of preeclampsia, even before proteinuria develops. And also we see electron-dense deposits of albumin, immunoglobulins, or fibrinogen, and also subendothelial fibrinoid deposits that are seen in the electron microscope.
Yeah, so basic pathology will be a glomerular endotheliosis. Of course, we don't do renal biopsies in pregnancy most of the time, but this is what the background pathology is. Dr. Bharti, how I know Dr. Arun already told we look only at the urinometer, but still there are other factors. So how is AKI diagnosed?
So basically, as we learned just now, that there is no standardization. We have 2, 3 criteria for general population. According to that, if you go by this acute kidney injury network, they says that if there is a rise of 0.4 milligram per deciliter of creatinine, we should suspect first stage AKI. Similarly, in pregnancy, if there is a rise of 0.3 milligram per deciliter, we should suspect kidney injury, like AKI in pregnancy. But the problem is that we don't have any baseline renal function test of our women, so it is very difficult. So the best part is comprehensively you evaluate your patient. If you're getting a patient of thrombocytopenia or high blood pressure, so give a stress on her creatinine also. So these are the important points which we can take care, and at least we can diagnose the women early with a deteriorating kidney function. That is the important point for our women, like, in stage 1.
Yeah, absolutely. So we need to put the whole picture together and then try to come to some conclusion as to what is happening to this patient. Dr. Sushma, what investigations would you order for this patient now?
So the investigations here would be, because it's a case of HELP with AKI, it's a conventional renal function test, that is creatinine, blood urea nitrogen, peripheral smear to look for hemolysis, like spirocytes, crenated RBCs, LDH, complete blood picture, then a coagulation profile, that is PT, APTT, INR, LFT, and to look for any sepsis, blood culture to look for any sepsis, and imaging, the ultrasound abdomen to look for the kidney and its damages.
Yes, absolutely. So we need to do an entire gamut of investigation so that we could at least pinpoint a cause as to where is the issue. And renal biopsy is a little controversial topic during pregnancy. We do a renal biopsy only when there is an equivocal case history and the renal sign suggesting either a glomerular, vascular, or an interstitial lesion. In my hospital, most of the time we have done a renal biopsy because when we were suspecting SLE as the cause and we have not been able to identify the actual cause, we have done renal biopsies during pregnancy and obtained the result without any much issue. So it's not that it's an absolute contraindication, but try not to do a renal biopsy during pregnancy. Dr. Malini, can biomarkers help us?
Biomarkers like S-plate, that is soluble FMS like tyrosine kinase 1 and the PLGF have been proposed to identify preeclampsia or differentiate preeclampsia from other mimickers. But in this acute setting, we have to look into the availability and the turnaround time as well. Usually the S-split PLGF ratio, which is less than 38, it almost with 99% surety, it rules out preeclampsia. But PLGF alone, the value of PLGF alone less than 100 is a marker for preeclampsia, is what is known in the studies. But there is no biomarker which can rule in, like saying, okay, if the value is more than this, this is going to predict preeclampsia, or this is going to say that this particular condition is preeclampsia and not other mimickers. So we do not have an accurate test for ruling in, but we do have this split PLGF ratio less than 38 as ruling out. More than 38 is considered as screen positive. But then again, with the sensitivity and positive predictive value of only around 30 to 60%.
Yes,
various other biomarkers are still coming up.
We do not have any biomarker which would actually pinpoint that this patient could lead you into a AKI. But I've got some good news. The glycosylated fibronectin is going to be reintroduced in the Indian market, possibly from next month. And if it comes, it would be a fantastic, because I've used it for many patients and it's a very good point of care test. You get your result in 5 minutes. And well, let's hope that it's available. And the cost is much cheaper. In India, everything we need to, consider in terms of cost. So if this test comes in back, maybe it would be really good to manage these patients. Dr. Arun, this particular patient has gone into AKI now. Now, how would you manage her?
Yeah, we have to remember that it's not as simple as saying preeclampsia, because the lady has a very right to develop all the other problems which can cause AKI. So biomarkers become difficult to even the ATN biomarkers are useless even for regular AKI. So out of question in this one. So management obviously will be correcting the pre-renal factors, renal factors, and the post-renal factors. See that the catheter is in place and draining. Never ever do a bladder wash, which is the most single way you can introduce infection up to the kidney. So see to that the catheter is patent. Then see to that there is no bladder distension. See to that the fluid status is acceptable. Very difficult to make out, including if you do a echo for the IBC also, you may not have a proper this one because the lady is already bloated up, and with preeclampsia, they don't know what is the cause for the fluid status, whether it is the interstitial space or is it a fluid overload intravascularly. So you can take help of a echocardiogram to see whether there is definite rise in fluid. Yes, there is some amount of help you may get by things like proBNP, where you can make out cardiac failure, but they do not really help much. So basically see that the patient is adequately has enough fluid, see to that the patient has enough blood in her, and don't wait for things like creatine, because creatine can go up only by about 0.3 to 0.4 per day, even with a totally shut down kidney. So by the time it goes up, it takes some time. So depend on the urine output, and of course, depend on the nephrologist.
Yeah, thank you. So this patient particularly, we need to take care as to how we give her magnesium sulfate. Either we could give her magnesium sulfate in a concentrated dose, or we may have to knock her out, put her on a ventilator, and then give her a magnesium sulfate. And the other important point is a renal failure patient is an indication for magnesium level estimation. Generally, when we give magnesium sulfate therapy, we don't have to do an estimation of serum magnesium levels, but this would be one of the cases where you would like to do a magnesium level. And also remember that whenever AKI develops in the antenatal period, it's an indication for delivery. Okay, what are the special care with drugs in AKI, Dr. Bharti?
Sir, you have already covered, like for magnesium sulfate, we need to monitor the level. Similarly, we should avoid all the nephrotoxic drugs. And we should also take care of the, like, suppose a patient is going for dialysis, we should take care which drug is we going, especially for antibiotics also. We need to take care of those drugs also, whether patient is going soon after, suppose patient is in sepsis with AKI. But we are talking about this particular case. So in this case, we need to take care of the magnesium sulfate levels, sir.
Okay, what antibiotic would you like to use in these patients?
Sir, this case we don't need. Like, this is a case of
We have
preeclampsia.
done a surgery on her. We have to give her some antibiotic or this prophylaxis.
So we usually give cephalosporins are the prophylactic we
So
give.
cephalosporins would be.
Yes.
But okay, I will throw a googly at you. Cephalosporin will cause a drop in platelets. Her platelets are already very low.
Sir, see, we need to take care, but anyway, these doses is not going to affect because there is already a pathology which is responsible for thrombocytopenia. So we need to give her broad spectrum antibiotic, but she is at the risk of sepsis also because she's obtaining the dialysis also, and we have done her cesarean also. So we don't need to take care of such, like we can give cephalosporin safely. That's what we are doing in practice. We don't
Any addition, Dr. Arun?
Yeah, basically everything under the sun, including the sun, can cause renal dysfunction. So you don't have anything safe. So you have to balance it out. But definitely there are drugs which can cause problems. In older days, we didn't have too many choices, but now we have choices, so we can use them. Cephalosporins can cause, similarly, all the penems can also cause changes in the coagulation profile. So you really don't have a choice but to use them and monitor them. But definitely avoid drugs which like NSAIDs, which you can definitely avoid even without without kidney injury, don't cause kidney injury. And especially the drugs, anti-diabetic and anti-hypertensive drugs are something which you have to be very careful about, because many a time we see that somebody else will come in, either a cardiologist or a physician will come in and add a ARB or the new SGLT2 inhibitors or sometimes added, which can contribute to the worsening. So be careful about them, and it's very difficult to really recommend a set of drugs which can be used in this one. Coming to
now you all understood why I called Arun my enemy, because all his patients create such problems. You don't know what to give to them. Dr. Malini, what have you been using in your hospital if you have a patient with HELLP syndrome, low platelets, AKI?
We do use cephalosporins, which are renal protective, like ceftriaxone. And if we are, as per the culture sensitivity, in case of sepsis, if we require anything, we'll go with the peptides with the renal dose adjustment.
Okay.
Sir, we always give
Dr. Arun,
antibiotic.
sorry.
Sir, we always give antibiotics in consultation with nephrologist also. So we always keep ourselves safe.
That's good.
Dr. Arun, I know you have covered, but we would like to give you in a very few simple sentences, what will be the role of RRT in this patient?
Yeah, the most important thing to remember is if you are considering a patient who has had a worsening renal function, consider RRT early on. But there is the caveat is that you already have a patient who has multiple organs which are involved. It's almost like a multiple organ dysfunction syndrome. And the liver is definitely involved. The cardia is already depressed. So offering any dialysis can also be a little iffy, but do use it early on so that before the blood pressure drops, if you can offer dialysis, it will be much better. Thankfully, we have newer modalities like both slow dialysis, like CRRT, and even diafiltrations, which can be much more gentler in dialyzing the patients. So, if you want to consider dialysis, do it early on instead of waiting. With safety coming in for dialysis, it is better to be proactive than to be late. But remember, dialysis can itself lead to coagulation disorders. The platelets can fall with dialysis. And of course, there's always the worry of some heparin entering somewhere in the system, either just from the catheter. And of course, you'll have to put in a catheter, which can be dangerous when you have a coagulation profile which is deranged. But if you are seeing things are worsening, it is better that you intervene early rather than wait till the patient becomes hypotensive and then try to do something.
I always argue with Arun. Arun, could you please stop using heparin for the dialysis? And he says, no, I have not used heparin. But now we know that even if we don't use heparin also, a dialysis by itself could result in some kind of a coagulation failure. So we need to be careful about it. And of course, whenever these patients are very prone to fluid overload and pulmonary edema, we need to watch for it, and they may become an indication for dialysis in these patients. Dr. Sushma, the next question to you is: the risk of future end-stage renal disease increased after preeclampsia?
Yes, sir. That's because preeclampsia is a broad spectrum disease, which is mainly happening because of endothelial dysfunction. And this endothelial dysfunction is the cause for this multi-organ damage, and which is affecting overall the renal, hepatic, cerebral, vascular. All the pathologies happen because of the endothelial dysfunction and angiogenic and anti-angiogenic imbalance. So the same pathology affects the end organ, the kidneys, to lead to increased risk of end-stage renal disease.
Absolutely. So it could be either that the preeclampsia itself has caused a permanent vascular injury at the glomerulus level, or that there was already a little bit of pathology existing there, and then it came out as a preeclampsia and then finally landed up with ESRD. So it would depend on an individual case. So this patient, in view of rising creatinine and potassium levels, was dialyzed. In the next 48 hours, we had to give her 18 units of blood and blood products. Patient improved symptomatically in about 72 hours, but the renal problem persisted. By the end of second week, the urine output started improving. And at the end of third week, she was absolutely fine with normal renal function. 2 years later, she became pregnant and underwent an MTP. 1 more year later, she was pregnant again. She continued the pregnancy. She was monitored closely. LSCS was done at 35 weeks for IUGR and mild oligamenous. Her PET profile was normal at that stage. We had a 2 kg baby, absolutely no problems. And I told her, I'm not looking after your pregnancies anymore. I'm going to do a tubectomy. And we did a tubectomy so that her obstetric career comes to an end. Dr. Malini, what are the CKD associated with preeclampsia?
Chronic kidney disease per se is a risk factor for developing preeclampsia in pregnancy. So in the reproductive age women, we usually see IgA nephropathy, we see reflex nephropathy, focal segmental glomerulosclerosis, lupus nephritis in women with CTDs, and in type 1 diabetics, we see diabetic nephropathy. We also come across women with the post-renal transplant as well. So if you look at the staging of CKD, even stage 1 CKD has an 8% chance of developing preeclampsia. And the risk increases as the stage progresses to up to almost 50% beyond stage 3. So if you look at when stage 1 CKD is women with single kidney or even live kidney donors, though the creatinine and all are normal, even for them, the risk for developing preeclampsia is high.
The one thing is, please look at the kidneys every time you have a preeclampsia patient, because I've had referrals coming in to me with the previous delivery. There was a preeclampsia, and this time there was a severe preeclampsia. And when we did a scan, we found that the patient was suffering from adult polycystic kidney disease. Now, once the patient has adult polycystic kidney disease, the connotation for the fetus also changes, because being an autosomal dominant condition, it could cause problems in the baby also. So please watch out for it. Make sure you do a kidney scan every time you have a patient with preeclampsia. You will also be protected because you can look at the renal cortex and see whether there are any changes that have already come in. So with this, we quickly go through a second phase. Akshita, how much time do I have?
So about 15 minutes.
Oh, okay, fine. So this is the story of Mrs. M, a 31-year-old gravid to abortion 1 with 8.5 months of amenorrhea, not perceiving fetal movements. She was an SLE patient on HCQ and steroids with superimposed preeclampsia on antihypertensives, and she was referred with complaints of bleeding PV and pain abdomen. She had a history of joint pain with fever 3 years back, diagnosed as SLE arthralgia. Then she got married and she was started on tablet HCQS 300 milligram OD. First pregnancy was a spontaneous conception at 24 weeks, and IUD with hypertension was present. There were no post-abortal complications, and the BP settled to absolutely normal 2 days after abortion. The second pregnancy, unfortunately, she was not monitored very well. It was taken a little casually by the obstetrician to whom she was going to, and the scan done, this was in 2014, showed a 28 to 29 weeks gestation at 28 plus 5. There is no FGR as such. Patient had high BP about a month after that, and at 30 to 34 weeks, she was referred with tense, tender abdomen with FHS being absent. There was PV, there was an active bleeding. Her hemoglobin was only 5.2. Her C3 levels, the complement 3 levels were 66.1 milligram per DL. They were within normal limits. And creatinine was 3.7. So this was a kind of accidental hemorrhage she had, a huge kidney tray full. The placenta was almost fully separated. This is the IUD for the baby. And of course, she had a massive PPH after delivery. We have put in a central line. Even the central line was bleeding all the time. Now, this patient was put on plasmapheresis. And on PVD, post-vaginal delivery day 12, she threw one episode of generalized tonic-clonic convulsions. She was ventilated, dialyzed. 15 cycles of dialysis had to be done. 7 cycles of plasmapheresis was done on alternate days. And the CT brain, fortunately, was normal. There were no changes in the CT on brain. And she received a total transfusion of 87, including blood and blood products. She also developed ICU psychosis, and she had to be treated for ICU psychosis. At one stage, the relatives came and told me that our patient is dead and you're keeping her on ventilator just to make money. Then I had to explain to them, look, if she was old, I would have taken her off the ventilator, but she's young. Give me 2 more days to try. And fortunately, for patient's luck and my luck, the patient came out of ventilator in 2 days. And of course, she came back to me 2 years later with a pregnancy. And the first thing I told them was that if your patient dies, don't blame me. And she will definitely go on ventilator. Don't tell me stories like you told last time that you have put a patient on the ventilator unnecessarily. Now your patient is alive. She has even also managed to get pregnant. So be thankful to God. So Dr. Bharti, nephritis and preeclampsia has got overlapping clinical features. How do you differentiate preeclampsia from nephritis?
Sir, it's very difficult sometimes. I would like to highlight here for all the audience. See, the lupus nephritis and preeclampsia have overlapping features, but why we want to differentiate? Because lupus nephritis will be treated by immunosuppressive treatment. Then only that patient will get better. But for preeclampsia, we require termination of pregnancy. That's why it's very important to differentiate both the conditions. But problem is that we have got 2 or 3 important points. See, we need a multidisciplinary team and a comprehensive review of each and every case to look for whether it is a lupus nephritis or preeclampsia. If these presentation is before 20 weeks, it is sometimes easy to differentiate between lupus nephritis and preeclampsia. And usually lupus nephritis comes before 20 weeks. And these some markers like complement levels and DS double standard DNA antibodies, they help us to clinch the diagnosis. But you always remember that complement level can be normal in pregnancy because of the physiological changes. So whenever there is a complement level low to normal, you suspect it is a case of lupus nephritis. But as sir, as you have discussed the case who came in third trimester, because it's very difficult at that time when you want to save the baby also, it's very dicey situation whether because that termination can aggravate lupus nephritis. So it's a very difficult situation where you had to manage patient with, but if the same patient would have come at 20 weeks, we could have thought of, we could have thought of for medical termination of like without taking that care of baby, we could have given her high dose of steroids or cyclophosphamide and treated her nephritis part first. Then we could have think of baby.
So again, I repeat, you understand why I called Dr. Arun an enemy. Because the kidney diseases are during pregnancy are terrible. It's very difficult to handle them. Okay, the next question to Dr. Arun. Anemia is often associated with preeclampsia, and most of the CKD patients have got anemia. So how do we manage this anemia in CKD patients to prevent preeclampsia from coming in when they are pregnant?
Just a continuation from the last question. We know that hypertension cannot be there without there being some abnormality in the kidneys. The same thing holds good for preeclampsia also. So if you have normal kidneys, you won't be developing any of these problems. The second thing is a good urine analysis. There is no substitute for that. Even done, ideally done even before the first trimester itself. You give importance to protein traces or about 4 to 5 RBCs in the urine. Probably the only differentiator between a nephritis and a preeclampsia would be presence of RBCs. If RBCs are present, you can be sure that there is something more happening than preeclampsia itself. Yeah, anemia will be a part of most of our patients because of the nutritional status, because of the chronic disease itself. But most important is look at the nutritional status, do a iron profile, do look at the vitamins, but a properly done peripheral smear is what will help you the most. It will help you in improving the diagnosis and replace all of these. Thankfully, we have good preparations now which do not cause too much of problems, correct the iron deficiency, supplement sufficient vitamins, and of course, the need for erythropoietin, if it arises, can be used very safe and can be used even for a short term. And we have enough various erythropoietins, darbepoietins, even pegylated erythropoietins. So we have a huge array which we can use and we can achieve better levels.
Dr. Arun, most of the obstetricians are not very adept at using erythropoietin. So could you just tell us about the dose, how you give, what you give?
First thing, never give erythropoietin till you have corrected the iron deficiency, because it will worsen the iron deficiency when you use erythropoietin. So the simplest way of giving would be a simple alpha or a beta erythropoietin. About 4,000 units would be 4,000 units to be given subcutaneously once a week will be a good starting dose. There may some patients need a higher dose, especially when there is renal dysfunction. But always remember two things: that erythropoietin can worsen hypertension, it can worsen hypercoagulability. Be very sure that the hydration is well maintained when you use erythropoietin, and monitor the blood pressure. And though in the most pregnant patients, it shouldn't cause too much of a change with blood pressure, because you are going to use it for a short-term blood pressure becomes worse only with the long-term use. But whenever you use it, please look at blood pressure. Using IV preparations of iron, if the transferrin saturation is anything less than 20%, is a must. Preferably now, I'm sure the pericarboxymaltoses and isomaltosidase are also found to be safe in pregnancy. Sorry. So these have to be used, and use high doses. Don't use 100 milligrams and all that. The rule when I was a student in obstetrics was total dose infusion. It still holds good today. Try to give a total dose infusion.
Approximate
Look
cost?
at reticulocyte counts.
Cost of the drug?
It's not too bad. Even now the cheaper ones of ferric carboxymaltose or isomaltosidase are available for as low as less than 1,000 rupees for 1 gram. Only one injection, that you have to remember. It may work out cheaper than giving daily doses of iron. The other thing is the iron oral supplements you use. If you use the older things like ascorbates and other things, they may not have adequate absorption. We know that
You can do your IV iron.
Epsidin. So use the newer ones like the chromosomal ones, which can have better absorption.
Absolutely. So the management goals in this patient would be a disease control, make sure the patient is in remission before pregnancy, avoid drugs that harm the fetus, detect preeclampsia promptly and identify placental insufficiency promptly, discern between exacerbations and preeclampsia, and appropriate detection and treatment of lupus flares becomes very important. Dr. Malini, the question to you, how very short, I know these are all big topics by themselves, but quickly in a nutshell, how will you identify HUS, TTS, AFLP? How would you differentiate them from a regular, let's say, lupus or a chronic nephritis?
There's always a lot of overlap. It is very difficult to differentiate clinically. Most of them will present with microangiopathic hemolytic anemia, low platelets, raising serum creatinine. The timing of presentation can give us one clue. AFLP usually in the third trimester, HUS mostly usually in the postpartum period. But then again, we cannot, it is no absolute differentiation or a discrimination. The parameters that you would look at are the presence of schistocytes, that is the hemolysis in the peripheral smear, the kidney function, the platelet count, the liver function. In AFLP, which usually presents in the third period, there is not much of hemolysis, but then there is a elevated liver enzymes and coagulopathy, hypoglycemia, and increasing ammonia. These are the points that clinches the diagnosis for AFLP. The other MAHAs can present to plus or minus the altered mental status or fever or renal dysfunction. HUS more of a renal dysfunction. In TTP more of a brain involvement, so altered mentation and all. The pathognomonic thing is that if you are considering severe preeclampsia or health, they recover after delivery. So if the woman is not recovering after delivery, you should have the TTP or HUS as the differentials and initiate an early plasma exchange or a plasmapheresis. ADAM-TS13 levels are known to be less than 10% in TTP, but again, the availability, the turnaround time, it may not be very suitable for us. Even if you are sending a sample, if you are getting a the report after 3 days or a week. In most of the
No
centers
use.
where they are outsourced, it is of no use. So going by the clinical picture, no improvement after delivery, then resort to early plasmapheresis, plasma exchange, and keep these differentials in mind.
Thank you, Dr. Malini, for a very good coverage of that point. So with this, we come to the end of our panel, and the key points were that the non-obstetric and obstetric etiologies may lead to AKI during pregnancy. AKI can occur at any time during pregnancy. Early recognition by decreased urine output. I think Dr. Arun brought out that very well. Look at the urinometer. And he brought out another point also very well, was that look at the urine microscopy. High-tech investigations are there. Definitely, we may need to do them. But these two simple investigations would give us a lot more information and at much cheaper cost. CKD in pregnancy increases the risk of preeclampsia and uteroplacental insufficiency, and in select cases of severe CKD, permanent renal damage could occur. Renal transplant patients with adequate immunosuppression may have successful pregnancy, though there is a increased risk of both maternal and fetal adverse outcomes. And timely intervention and a multidisciplinary team is very important to prevent and reverse the kidney damage that has occurred. So MFM specialists and nephrologists must batten down the hatches and try to ride out the storm together in those patients who are determined to sail. So the patient should also be determined to sail. Then we can together as a team take the patient across the ocean. Thank you very much. And I think all my panelists did a wonderful job. Please give them a big hand. Thank you.
Thank you so much, sir, for moderating such a wonderful panel. And thanks to all the esteemed panelists for actively participating. Now, I request Dr. Harini to speak a few words about PENAI. Madam is a clinical director in Ovam Hospital, Kalyan Nagar, and she's our PENAI coordinator, EC member of SMFMI. And Madam has publications to her credit and is interested in high-risk pregnancy care, reproductive medicine, and infertility. Over to you, Madam.
Thank you, Dr. Akshata, and thank you, Dr. Prakash Mehta and Dr. Revati, for giving me the opportunity to talk on the success of conducting the PENAI program in our center. I deem it as my privilege to talk about our success on organizing the PENAI on-site program. We have about 6 branches, that is the home group of hospitals, which has south and north zone of Bangalore, and 2 centers. We have a semi-urban area, that is the Hoskote branch. Each unit we have 600 deliveries per month. Recently, we had come across of a scenario where we had to refer the mother after the LSCS because of the preeclampsia, atypical eclampsia complications, where this patient after the LSCS needed a ventilatory support to the higher center. In spite of our best efforts, we couldn't save the mother. So this inspired us to do the PENAI on-site program in our center to educate all the clinicians in our centers, that is coming from the south zone of Bangalore and our Hoskote branch, where it covers the semi-urban areas, and to upgrade the knowledge of the clinicians and to upgrade the facilities in our center to prevent these type of complications, especially atypical preeclampsia, which is the preventable one. This made us to to organize the PENAI program in our center to upgrade the knowledge about the PENAI program to save hands, join hands to save the life. So this turned out to be a successful PENAI program at the corporate level, where we had 54 delegates, and all were so happy with the knowledges which was upgraded regarding the atypical preeclampsia, so that we can prevent the maternal death. Thank you, sir.
Thank you very much,
Dr.
Dr.
Harini,
Harini.
and it was great organizing a program in your place.
Thank you, sir.
Thank you, Dr. Harini, for that information. Among the delegates, we have Dr. Shashwati Chaudhary, Madam. Ma'am, if you're with us, Shashwati, Madam.
Shashwati Madam has joined on
the delegate
link, is
yes,
it?
yes, sir.
Oh, they may not
So
be
we
able to
could-
participate.
Oh,
You have to
okay.
be on a faculty link to participate.
Okay, actually, Revati ma'am, if you could
Ma'am
tell us.
Ma'am could put in a message.
Revati ma'am, if
in
you
the
could
chat
talk
box.
about the Penai as Assam that Dr. Shashwati ma'am will be taking over.
Thank you, Akshita. I think before we start Assam, I think Harini's milestone was very important for us because she actually kind of set it up in a corporate background. So this is kind of led to several other inquiries where we could probably put it, I mean, extend it even to corporate doctors. We've also had situations where these doctors have not been able to attend conferences because of their schedules. They were really happy that we could do it on site at a single place, and the pass levels were also very high. I think we had almost everyone certify during that program, and they're also still in touch with us, sending emails regarding clinical queries, which we, kind of extend help from the society. Sir, I think Dr. Saswati Sanyal wanted to take this program to Assam.
But how would she come in? She has to join by the faculty link.
No, sir.
She
You
has
could only
promoted to
talk.
panelist, sir.
You could talk about it, sir. Oh,
Okay.
we are. Yes. Can you?
Oh, yeah,
convert-
Dr. Shashwati has joined.
Yes. Dr. Saswati, welcome. Actually, we were talking about Penai coordinators. Now that we have about 625 registrations and we have about 400 plus certified delegates, we are also going across the country through the zonal format.
I think the next program is Gorakhpur,
Yes, that is the on-site version.
the
And
on-site version.
Yes, the South Zone online. So we would want you to probably let us know about what would be the take about taking Penai to the east of India.
Sorry?
I think she should unmute herself.
Yeah, Dr. Shashwati has joined. Let her finish
Yes,
speaking.
yes.
Because we have only about 5 more minutes left.
Yes, sir. I invited her, sir. Yes.
Yes. Yes, thank you so much for,
Now,
allowing me to
before Dr. Shashwati says anything, I must say she has been a solid pillar of support for us. And she has done a lot of work on preeclampsia, has a great interest in preeclampsia. And always, we just have to tell her, come, and she's there with us. Thank you, Dr. Shashwati, for being so great.
Yeah, thank you so much. And I must congratulate you for the beautiful panel discussion you have done today. It was excellent, very simple, very crisp information. And the other two talks were also very, very excellent. Hats off to all of you to giving us this opportunity to know about the renal disease and preeclampsia. I will try for this Penai in our medical college because recently we are going to have our Northeast NeoxCon program. So in this year, so probably in the next year, I'll try to do the Penai through our Guwahati Society or maybe in the medical college.
Great.
Thank you so much.
We'll be happy to do it for you, ma'am.
Okay, thank you.
Thank you, Dr. Saswati
Maybe
ma'am,
that
who
be the
joined
first
us.
initiative in the East, madam. So I think you should be the leader there.
Yes, Akshita, vote of thanks.
Thank you, sir. It's my greatest privilege to deliver the vote of thanks on behalf of the Society of Maternal and Fetal Medicine India and the event coordinators, Dr. Anu and Dr. Srimati Madam, at the end of this enlightening academic session. This is our third episode in the second series of the virtual learning series on preeclampsia. Firstly, I would like to extend my heartfelt gratitude to our esteemed speakers for sharing their valuable time and insights with us on renal disorders. The knowledge and perspectives provided today have truly enriched our understanding and inspired us to continue our learning journey with enthusiasm and dedication. It was great to see that many delegates have participated here today. We're excited about SMFMI growing across the country. We thank our Sir Dr. Prakash Mehta, whose vision, constant support and guidance brought us this far. Dr. Revati, whose hard work has made SMFMI grow leaps and bounds. I'd like to thank Dr. Revati for giving us coordinators this opportunity to work for SMFMI and encourage us youngsters to be involved in various academic activities. We'd like to thank wholeheartedly Professor Sarosh Rana Madam and Professor Anne Mary, who have guided us and helped us collaborate with iShip and helped us being visible on the international platform. It's an honor to have them with us. I'd like to thank Dr. Renuka for her exhaustive description and discussion on preconception care in a woman with pre-existing renal disease. I thank Arun sir for his elaborate enumeration on renal diseases requiring dialysis before, during, and after pregnancy and childbirth. I thank all the eminent panelists, Dr. Malini Madam, Dr. Arun sir, Dr. Bharti Madam, and Dr. Sushma Madam for their seamless discussion and sharing their insights, extensive experience, and expertise with renal diseases in pregnancy and preeclampsia. Thank you, Dr. Harini, for the update about how PenI could help in a corporate setup. As we bring this wonderful event to a close, it's my honor and privilege to extend a heartfelt vote of thanks to the amazing team who made today possible. Team Shield Connect, our knowledge partner, and their members, Mr. Balaji, who's a Vice President at Shield, Mr. Sri Ram, who's our regional coordinator, Ms. Chitrakala, and Ms. Sahiti. And also thank the EC members of SMFMI for their hard work, dedication, and passion. A special mention goes to the behind-the-scenes staff of SMFMI, the office staff, Mr. Shrikant and Mr. Rajgopal, who ensured every detail is perfect. They work tirelessly, meticulously, and ensure that everything runs smoothly. Your efforts are truly reflect the commitment you have to our society and to make every event perfect. Lastly, I extend my gratitude to all the delegates who are present here for their active participation and attention. Let us all carry forward this knowledge we have gained today and make the best use of it in managing our patients and saving lives. Once again, thank you all for being here and making this session